Good evening, everybody. First of all, on behalf of Team AIG, I would like to welcome you all for the symposium on HCC. And I would like to take this opportunity to welcome Dr. Amit Singhal from University of Texas. And he is Distinguished Professor of Hepatology and he's chair of a tumor board, chairman of tumor board at university. So he has special interest in liver cancers and we going to have a feast of academic feast on this particular topic. Friends, as you all aware that HCC is a leading cause of cancer related deaths all over world and India is no exception. The demography, the epidemiology is changing and NASH and MAFLD is on the rise and that is also contributing a large portions of HCC. Earlier we had HBV related HCC. Along with that, HCV was never a major problem, unlike the West in our part of the world. But HBV was a major concern and still continues the major cause of HCC, and NAFLD is on the rise. So all these epidemiological issues and all, now we have better understanding of molecular pathogenesis of HCC. And with this better understanding, what has emerged that we know there are several molecules are on the horizon. Some have already come up, and now we have a lot of data to say which drug has to be used in which group of patients. Not only the drugs, these molecular antibodies, this is a multidisciplinary approach because we have role of our medical oncologist, we have role of our interventional radiologist, we have radiation oncology, and on the along with our team like hepatologists and surgical team, and lastly the transplant. So all these gamut of issues we have to discuss, and our team has made a small, very brief, and very interactive program to discuss all these issues on HCC and what is the role of different molecular antibodies and what are the new molecules, and to discuss all these issues we have a number of speakers, especially from our team. And in addition to that, as I said, the main speaker is going to Dr. Amit Singhal. As I said, he has special interest in HCC and he has several publications to his credit. And not even that, he is served as co-chair for drafting ASLD guideline on HCC. So he's the right person to be with us. And I welcome again Amit to AIG. And with these words, I would like to invite our first speaker, Professor P.N. Rao. He is going to talk about epidemiology of HCC in India, past versus current, because the epidemiology is changing and what are the current changes. He is the right person because he can take us through the past to the current level. Dr. P.N. Rao, sir.
Thank you, Dr. Rajesh. Well, when it comes to epidemiology, I think one single sentence we can say as far as our country is concerned. The answer is that we don't have a good epidemiological data. This will be the start and this will be the end of my topic, actually, right? And only second line is that NAFLD is increasing, hepatitis B, we still do not know whether it's increasing or decreasing, right? But I have to tell you the story, right? Because Anand asked me to speak on epidemiology. I said, I'll have only 2 slides with me, but he's given me 20 minutes, right? So then I have to take you to the entire story, what has happened before, and then what is happening now, and perhaps what is going to happen, right? Thank you. Right, okay. It's always good to start with some index patients, because it creates some kind of an interest and it is a related. You see here on the left-hand side, you see the index patient who was a mother, 38 years, and she was detected to be HBsAg. She is the index patient. And then she is being treated. Right side, you see the family tree, unconventional writing of the male and then female, but still this slide was made about many years ago. But still you can make out that she had 3 children and among which one boy and then girl, one was an inactive carrier, and the another girl has been on the treatment. Look at the 21 years boy who is in the red there, square, and he was detected incidentally when his mother was being treated, but he was losing his weight recently, and then in fact he lost his weight from 72 to 56 kilograms, but he did not know why it was that was been happening. Why that's been happening, right? And then when his mother was detected, then he was found to be, lo and behold, not only that he had a cirrhosis of liver by that time already, grade 1 varices were there, but unresectable advanced malignancy, right? And it's not unusual. We keep across. And usually at this age, we usually see non-cirrhotic hepatomas. But this guy already had a cirrhosis of liver also, and then he's developed this one. And subsequently, of course, it has been proven he died, sooner, about for 3 months later, he died. Look at this family, all are positive. And one is an inactive carrier, this is, as on that day, it was an adipavir, the other was lemit, right? And this is another, this lady, literally I've been following her for nearly 20 years, HbSAg positive, ALT perfectly normal all the 20 years. Not a single time she crossed the line. And what does our guidelines say? Don't treat them. Of course, this was based on the previous levels of a 40. We are not uniformly following the 19 and the 30. But still 40 is being followed for upper limit to the normal for both the sexes, right? It was, of course, she developed a comorbidities later, like a diabetes and then obesity, and then she became obese. But the son, he was detected, and later, at a very young age, he died of HCC. Here, 2 points. ALT was normal totally, and then suddenly she developed cirrhosis. Maybe I think the comorbidities like diabetes and obesity have contributed for her liver disease here. So, this scenario belongs to 2006 or 7 or so when I came to. But look at here, today outpatient, incidentally, I has to happen. And look at this course of events. 2nd, 4th, ultrasound done for a pain in the abdomen, SOL with necrosis, size this much. Then CECT was done, reported as a hemangioma. This is not uncommon. CECT reported outside elsewhere as a hemangioma, which gives a false sense of security to these people. They go on and they come to us later with a large tumor by the time it is unresectable. Later, of course, DNA, then tenofovir has been started. Then the another bright ultrasonographer, he's done, and it's clearly depicted everything he has told, regenerative nodules, CLD, and also portal vein thrombosis, he described about that one. And triphasic fetal and AFP was been high. So that means that she is 39 years. That means that at that point of time, 39 years ago, we did not have any universal vaccination was not initiated. So thereby it indicates that even every adult, irrespective, still they have to undergo for the screening and then vaccination in our country. And this has been what is our vaccination coverage? It's been a good review article. It's been shown that is very patchy. And only 45% of the children aged between were not vaccinated against. And the scenario is still not very far even today. The point which I'm making is that HPV is not going to leave us like in other countries. It is going to be there. It is going to be one of the predominant with, as we discussed later, along with the comorbid factors like diabetes and then hypertension, obesity, which are going, and is going to be added upon to that one. So this is the status here. And this is one of the first ones which is Professor Acharya from All India Institute has written about the epidemiology of hepatocellular carcinoma. And you see, look at here, at that time, a verbal autopsy. On the basis of a verbal autopsy, they calculated what is the incidence of the males and then females for so and so. I will not go into the details about that one. At that time itself, physicists said that Unpublished data from various tertiary centers suggest that the incidence of HCC is increasing. This was in 2014. And therefore, we do require a multicentric HCC registry. We still, after decade also, we do not have any kind of a unified multicentric registry is not there. And that's the reason why we are facing to collate the data across the country. And this one is that this is Acharya's article. You can see over the years, how the HCC has grown, and you see the NAFLD NASH, such a small bar at that point of a time. Well, then, what is our government doing? See, this is the ICMR policy document published. There is a lack of a nationally representative data, so we must depend upon autopsy studies, right? And national cancer registries and population-based surveillance data to estimate the frequency of HCC in India. This is about the autopsy study, which I have mentioned. Then again, there was a National Cancer Registry 2016, which represents work carried out by 28 population-based and 58 hospital-based cancer registries under the ICMR and National Center and Informatics program. But unfortunately, at that point of time, not unfortunately, because they were concentrating on public health, the tobacco chewing, smoking, and breast cancer, cervical cancer, that was their priorities at that point of a time. But they did not add any liver at that time. And that's the reason at that time we do not have any data, although this is sponsored by the government and then ICMR, we don't have a data on this. These are difficulties of acquiring the data from our country. Then we have got the Indian Cancer Society, but that was only an NGO, which was by Tata's at that point of Tata's, but this is only centered around only about few cities, Mumbai, Pune, Aurangabad, and Nagpur. And therefore, the Indian Cancer Registries also does not give us any information about what is the epidemiology, what is the correct epidemiology in our country. Neither the government do we have any data, nor this one. So therefore, there is a lack of data is there. That's the point which I'm making. I'm not criticizing or critical about anything, but why we don't have a data, and this is the one which we have now. This one I just show you that the wonderful article which Amit has had in the recent Nature reviews. There's a one-stop, as far as the epidemiology is concerned, you can go through that one. And this another recent one, again very nascent, 2023 article, where somebody collated all the data and did a meta-analysis of this. And here you can see here that this was before 2014, hepatitis B is this, and after 2014, this one. You can see that there is not much of a change between 2014 before and then after, and then hepatitis B is still there according to the meta-analysis here. But there is a lot of regional variations are there in our country as far as hepatitis B is concerned, which we'll go through. And then after 2014, when NAFLD is there, was very small bar, you can see here. And after 2014, it's risen. And this is mostly across most of the centers, it is there. Well, then this only shows that the viral is going down and the non-viral is going up, and the NAFLD is going up in the same article. But there has been a considerable heterogeneity in reporting the prevalence of etiologies across India. And this is what Dr. Anand has written an article on this one and collated all the data here. Basically, it says that initial studies from India, higher burden of viral related causes as the dominant cause of HCC, and recent studies decrease in the hepatitis B and an increase in the alcohol related and the MASH related has been there. But then there is a lot of variability is there. Look at here in Kerala, it's only hepatitis B is only 7%. And look at here in Punjab, 54% hepatitis B. So the amount, because Kerala, as we know that, is a very, almost universal vaccination has occurred there, and the literary rate is almost 98 to 100% in Kerala, and therefore it's only 7% there, whereas in 54%. So there is a lot of variations are there in the heterogeneity is there, and this Dr. Anand has collated all the data. One can go through the article here about all the east, west, and every place here. And this is one of the articles in editorials which have recently written on the basis of the multi-center prospective study surveys in hepatocellular carcinoma in Kerala, more than 1,200 cases. And all the Kerala gastroenterologists came together and they have collated and then they have produced some real-time data is there. So here, hepatitis B is constitute only 7% in Kerala, and therefore that reaping the benefit of the successful vaccination is there. And the demographic pattern, again, you can see here that the obesity has been taking over, and diabetes 33%, obesity is diabetes 64%. So these are going to influence our hepatocellular carcinoma nevertheless, right? And this is a recent data which just Dr. Anand has collated just for this purpose. Of course, future he'll be writing this one. And 920 patients are there. You can see here that the NAFLD constitute about nearly 40%, hepatitis B 23%. This, of course, ours is a referral center, and then there is a bias is there in this particular one. But what is important to see is that see the diabetes and then alcohol and then diabetes. Very high percentage. Alcohol, diabetes, obesity, these have got a subtle influence on the hepatocellular carcinoma. We know that diabetes itself is a pro-carcinogen status itself. So that's what Dr. Amit Singhal has future projections is made, that on the basis in this particular article that this is going to increase by 2040, and MASH related is going to increase. Alcohol will still be there. We're going to see many combinations, many combinations. Every combination will be there with the virus is still going to be there with us. Thank you very much and for hearing. Thank you. No. NASH is increasing. Definitely NASH is increasing. But hepatitis B, we got heterogeneity is there. Northeast is still very high. Kerala is still within 7%. The heterogeneity which is there. But overall, if you see, even in 2000, recently, only 45% of the children are vaccinated. That means today born, he still is a prone for hepatitis B. And the one which I told you just now, 13 years old lady, you came just before that one. Today I got a patient with 13 years hepatitis B related carcinoma advanced. So it is going to be there, the patient. But combinations are going to be more. Hepatitis B, alcohol, hepatitis B, diabetes, or hepatitis B, diabetes, obesity, alcohol, all put together. And therefore HCC is going to increase in future because of these factors.
The recent strategy by WHO says that treat all. DNA more than 2,000, they say we should treat them. So do you think that will reduce the incidence of HCC? Dr. Amit, what do you suggest? Treat all hepatitis B?
The bar to treat hepatitis B is definitely decreasing over time. I think we're moving towards an era where we're going to be treating more. I think we still have to realize that there is some risk for lifelong treatment when you start at an early age. So I think there's still some bar of not treating everyone, but I can say that we've definitely become more aggressive in terms of where we used to be in terms of treating hepatitis B. So, I saw a patient, much like you've talked about, normal AST, normal ALT, sort of relatively low viral load, where in the past we would not have treated this person. Her mom had a history of HCC, actually cholangio later in life. And I told her, I was like, we should probably treat you primarily to prevent these complications. And I think this is where we have to realize that there's probably people that we would benefit from hepatitis B treatment earlier.
MASLD. How to differentiate, identify? MASLD is now like broader term. Everybody is MASLD. And that's diabetes.
That was the figure that you showed, that even among the viral cases, a lot of these patients have diabetes, a lot of these patients have alcohol. And so the issue there is that those patients are higher risk of developing these complications. One question is, if you treat the hepatitis B, you're going to mitigate the risk but not eliminate it, because you still have the ongoing diabetes, you still have the MASLD. So when you take a look at, for example, patients who are post-SVR, this ongoing risk of developing HCC, ongoing risk of developing liver-related complications, many of those patients actually have MASLD that's going on in the background, or ALD. It's So it's tough. You have to treat the entire thing. Now the question will be, and I think this will be the interesting thing, is now as you have GLP-1s, you have these other medications, and you are able to treat the obesity, the diabetes. What is this going to do for HCC? No, yeah.
Yeah, no,
I think this.
the reason the obesity and diabetes are very prone for it's called carcinogenic, actually, diabetes, is that if you take a standard 1, obesity alone will have a 1.5 hazard ratio, obesity alone. And diabetes alone, 4.5. Diabetes and then obesity is about 5 times more they are riskier. All the malignancies, not HCC, all the malignancies will be there. As far as hepatitis B is concerned, I am just looking for an opportunity to treat a patient. Even if 31, now whenever I want to treat him, I take a 30 and 19, right? And other things like a family history, HCC, and other things will take care of that. And also the fibroscan also is helping us nowadays. If it's a high, definitely irrespective of OTPT, we treat them.
Sir, the more than the treatment, it is the prevention which is matters a lot. Because this data, which Taiwan studies has clearly shown, once they started immunizing these patients, the incidence of HCC is significantly. So irrespective of treatment, even if you treat these patients, because you cannot get rid of the completely obliterate or completely annihilate this, because this is a virus which is integrated in the cells. Until unless you take a preventive measure, because mass vaccination, it is going to take second generation, because now our generation, just Dr. PN has shown that it is only 45% patients or children are vaccinated or adult population is vaccinated, which is a very, very low for a country like ours. Need to vaccinate rather than treat. Our focus should be on preventive measure. Of course, these patients, what Anand has raised this issue, should we treat all patients? I feel anybody who is more than 35 years should be treated, irrespective of DNA.
I agree with you. I mean, prevention is definitely the way we need to go. I think the one thing when we think about this is the vaccination rates are not distributed evenly across the country, right? I mean, when you take a look at this, I imagine the vaccination is very high in big cities. It's very low in villages where you don't have the infrastructure. But the treatment, you're going to be you're going to be implementing treatment in those same high medical resource areas. And you're going to be under-treating patients in those same areas where you don't have vaccinations. I think the big thing, to your point, is we need to have the medical infrastructure so you can implement this evenly across the country, and that's the way that we're going to eliminate hepatitis B. But I agree with you that prevention is definitely the way we need to go, and I think that towards this point, in terms of a population-based estimate of reducing liver-related mortality in HCC, it's helpful if we treat more and more patients. The one thing, though, when you're seeing individual patients, you have to think about that individual risk-benefit ratio, not just the overall, population basis.
We'll continue the discussion.
To prevent one HCC?
Yeah, so we have those. It's just the issue is that when you're taking a look at this, that risk ratio changes. I mean, so you can use things like the reveal score, these risk scores, and when you're doing a low risk population, if that number needed to treat is quite high.
The base is there. That
Page B, so the same thing.
So now we move on to the next talk, and Shantan is going to deliberate on the role of TKIs in the era of immunotherapy. Thank you, sir. I think we'll continue the discussion at the end of all the lectures. So we'll first finish the talks and then we'll.
Good evening, everyone. So, without much wasting of time, so we'll start off with the first topic. The topic given to me was the role of TKIs in the era of immunotherapy. So, with the further sessions mainly concentrating on immunotherapy, so I'll be briefing upon the current usage of TKI and what are the current studies going on. So this was in brief, all the revolution started with 2007, starting with the sorafenib trial, which is a sharp trial, which revolutionized treatment of undetectable HCC, which first time showed that the overall survival was better with the drug. Later on, many drugs were evaluated, but later from 2007, for 1 decade, there were no further medications which are available. 2018 started with the instead of lenvatinib trial, which was a reflect trial, which was a non-inferior trial with the sorafenib. And the major other revolution which had started, where the concept of immunotherapy started in patients with HCC, was the trial of bevacizumab and atezolizumab as a first-line therapy, which is IM-Brave 150. So the things which are mentioned in the green are all the phase 3 trials, and specifically sorafenib, lenvatinib, and atezolizumab and bevacizumab combination as a first-line therapies. So before starting off, I'll start off with a case. The case courtesy by P.N. Rao sir. So thing is, he is a 54-year male. He's an obese, maximum weight of 82 kgs, BMI of 31 kilogram per meter square. Has metabolic syndrome, diabetic, hypertension, hypothyroid. He was B negative and C negative. So the chronology started off with October 2021, where he was incident diagnosed to have cirrhosis, that time with having dyspeptic symptoms alone. The endoscopy was done, which showed grade 3 varices. This was in Bengal, where he was underwent primary EVL. The ultrasound showed a small lesion in the left lobe, 3.93 centimeter. The vasculature was not commented upon. The AFP was more than 5,000. And MRI, which was done, which was showing a large infiltrative lesion with a VP3 tumor thrombosis, with mainly the left portal vein up to the MPV confluence. So basically, this is small infiltrated type of lesion where the lesion mostly concentrated in the left lobe. There was a flow void which is seen in the left portal vein. The right portal vein is the flow void can be seen. There's a left portal vein. There's an expansile tumor which can be seen. And on the diffusion restriction, there is a large infiltrated type of lesion. So maximum measuring around 7 into 4 centimeters. So coming to the point, though, that final diagnosis was cirrhosis. It's muscle related with compensated, coming to BCLCC with the VP3 tumor thrombosis, AFP of log 3, child A6, male of 8. An ALB score of -2.2 with a grade 2. So to the audience, what I would ask is, what would be the ideal treatment for this patient? Whether it's atezolizumab and bevacizumab, whether 2, it's lenvatinib, 3, TARE or plus atev and bevacizumab, 4 is TACE or lenvatinib, or 5, liver transplantation. So anyone going for first option? Sorry? No, he was not varicose. He was not having any variceal bleed. So it was only a primary EVL. It's primary EVL, sir. Primary prophylaxis. No, banding was done, it was in 10 and he came 1 month later to us. Okay. So anyone supporting 1? Okay. 3. Okay. So what happened to this patient, I'll come up later on. So first, the outline of my study, my talk will be based upon the pivotal trials of TKI, then the role of TKI in specifically NAS HCC, the combination of immune checkpoint inhibitors and TKI and TACE, and follow up with the case. So let's brushing up the prior trials on TKI. So there the landmark trials, which is a SHARP trial, which showed that sorafenib is superior to placebo in unresectable HCC. That is way back in 2008. Also seen in Asia Pacific region, Asia Pacific trial, which showed a higher median overall survival compared to the placebo. Next comes with the Reflect trial, which is a phase 3 trial in 2017, which showed that it's a non-inferior trial. So basically, which I want to concentrate is they did not stratify based on the AFP criteria. They are stratified based on the region, the microvascular invasion or extrahepatic spread, and the body weight. They have given based on 8 mg with less than 60 and 12 more than 60 as usual. And the end points were evaluated. But in the study, it showed that lenvatinib and sorafenib has an equivalent survival, and there was no statistical difference in the median overall survival, progression-free survival, or time to progression. But however, you can see that the objective response rate was way higher in the lenvatinib group compared to the sorafenib group. So there was a further assessment based on investigator assessment, along with an independent imaging review assessment done later, once the non-inferiority was established. And it was seen that the overall survival and along with the progression-free survival was statistically not significant. But however, in the anti-tumor effect based upon the overall response, along with the time taken for response, or time taken for progression is significantly better with lenvatinib group. So they have adjusted the AFB imbalance. So they was not stratified initially. So AFB they have stratified later on with less than 200 or more than 200. And they have been seen that initial, this is the overall median overall survival, which is around 13.6 months with the lenvatinib and 12.3 with the sorafenib. But when they have stratified based on the AFP, so that has a higher significant overall survival around 19.5 months, which is typically seen in the IMBRAVE 150, and along the sorafenib group showing around 16.3 months. However, with increase in AFP, the overall survival has come down to 10.4 versus 8.2 months. So this stratification was done later after the non-inferiority was established. So why lenvatinib alone was superior to sorafenib? So it is the only TKI which has activity against the FGF receptor pathway along with the VEGFR pathway. And FGFR pathway is known to have a role in hepatocellular carcinoma generation because it's involved in the tumor proliferation and anti-apoptosis. So coming to the much debated topic initially was the whether atezolizumab and bevacizumab is better with viral or non-viral, or whether you try TKI in patients with NASH. So because the topic is on TKI, I will be giving supporting evidence on TKI. So this is 2021 Nature article which showed that the NASH, it limits the anti-tumor surveillance in immunotherapy treated HCC. So when we see the subgroup analysis in IMBRAVE 150, when we see the non-viral HCC, it has shown a little significance but not gross significant compared to the patient when you compare to the viral. And the non-viral HCC is comparatively less responsive to immunotherapy. This is basically a meta-analysis comparing all the randomized control trials with checking all the randomized control trials of all the immune checkpoint inhibitors, not only atezolizumab and bevacizumab. It has shown that when you stratify into viral and non-viral HCC, the non-viral HCC has very minimal significantly difference when we take as non-viral HCC, while the viral HCC has significantly much advantage favoring the immunotherapy compared to the TKI. Also, the real-world evidence, which based on all the lenvatinib studies and atezolizumab bevacizumab studies, they're mostly from the eastern side of the world, from Japan and Korea. And the largest real-world evidence, around 2,205 patients, where around 1,300 patients of lenvatinib and 800 patients of the ati-beva group has been taken, and it has been seen that the overall survival, along with the time taken for progression, is similar in both the groups. Also, from the ESMO group, where an international propensity score matching analysis has been done. So analysis has been done in 3 stages. The first analysis was a multivariate analysis taking lenvatinib and atezolizumab group. Second analysis was a propensity score matching group. And the third analysis was a multivariate analysis taking only sorafenib and ati-beva group. And even in this group, so to the surprise, it has been shown that the overall group, the lenvatinib versus atezolizumab bevacizumab group, it has a significant higher overall survival, median overall survival in the overall population, but it was not statistically significant. But when it is delineated into NASH and non-NASH patients, so the median overall survival is almost 21.2 months as compared to 12.2 in ati-beva group, with statistically significant change in the median overall survival. So when we compare, in the non-NASH group, it is still non-significant. So all this status favors that the patients with NASH-related HCC better perform with TKI. But however, the certain real-world evidence show that there is no difference in both the TKI and the immunotherapy. So coming to my case, so this is a case which I've told. So this is the NASH cirrhosis with compensated along with the child A6 and male 8. He was unwilling. Initially, the advice for atezolizumab and bevacizumab, he was unwilling for the same because of financial constraints. He was started on lenvatinib, 8 mg per day. That was in October 2021. Dose adjustment happened due to side effects. He was on 8 mg per day for 6 months and 4 mg per day is continuing till now, which is almost in 3.5 years. This is the current MRI, which has been done only last 3 days back. The initially thrombus, which has been a tumor thrombus, which has gone, and it was only a bland thrombus now. The tumor which is initially seen there's no tumor which was seen now. The AFP trend, which is shown that it's almost starting with 6,300, now currently is 3.5, and he is on lenvatinib 4 mg currently. So it was only a loss of flow burden in the left branch of portal vein, and is currently he's maintaining complete response of the tumor. So further, after this case, I would like to see what are the future developments which is going on as a first-line treatment for HCC, incorporating the TKIs. The key trials which are the LEAP trial, which is the lenvatinib and pembrolizumab in unresectable HCC, COSMIC trial, case 310, which is mostly the Asian population rather than the Western population, and the launch trial, which incorporated lenvatinib with a loco-regional therapy like TACE. So TK and immune checkpoint inhibitors, does it make sense? So what is the benefit of addition of TK to immune targeted therapies? So basically TKs, it can normalize the tumor capillaries because of anti-VEGF. It enhances immune cell infiltration. It reverses the immunosuppression of the tumor-mediated cells and promote the release and presentation of tumor antigens for the action of immune-targeted therapies. So this is the LEAP-002 trial, which is lenvatinib and pembrolizumab versus lenvatinib. So 794 patients were randomized 1:1, receiving lenvatinib and pembrolizumab versus lenvatinib alone. And the treatment was followed till the achievement of until there is a disease progression or in any toxicity. Overall, the intention to treat survival, the overall survivor, they've seen that lenvatinib plus pembrolizumab and lenvatinib plus placebo has no significant change. There's a significant increase in the lenvatinib and pembro group compared to lenvatinib alone. But the important thing to be seen is that even the individual lenvatinib alone showed an overall survival of 19 months, which was far superior to the one which is shown in the REFLECT trial, which is around only to 13 to 15 months. So this 13 months even has been seen in Ati-Beva group, but why this? So even with lenvatinib monotherapy, they are suggesting that the patient will have a significantly higher overall survival. When we see that the progression-free survival, the lenvatinib and pembrolizumab has a higher overall survival compared to the lenvatinib and placebo group. And even the disease control rate compared with RECIST 1:1, then 1.1 or mRECIST, the combination group has a better advantage than the single treatment alone. So even the LEAP did not meet the pre-specified statistical significance, but it achieved overall survival of 21.2 months, which is the highest overall. Along with it, the side effects are minimal, and along with the current LEAP 012 study is incorporating lenvatinib, pembrolizumab, and TACE. So why the probable reasons for increasing overall survival with lenvatinib monotherapy in this trial? So in the REFLECT trial, there was imbalance in the baseline characteristics, and as I explained before, after dividing it to AFP based on values less than 200, more than 200. So with the lesser AFP values, it considerably did well with increasing the overall survival. Along with it, and so lenvatinib followed by immunotherapy is one of the treatment options which can be considered further. The other trial is phase 3 COSMIC 312 trial, which is first-line cabozantinib with or without atezolizumab versus sorafenib. So even this trial compared the TK combination with immune checkpoint inhibitor. So overall, the progression-free survival is significantly better with cabozantinib and atezolizumab group rather than sorafenib alone. So even the overall, the objective response rate and the complete disease control rate was significantly higher with the cabozantinib and atezolizumab group. The third trial, which is phase 3, which is open randomized study, is the combination of camrelizumab, which is anti-PD-1, plus the VEGFR2 targeted TKI, which is rivaroxaban. So basically, these are randomized 1:1 with 543 patients, and it's shown that the median progression-free survival and the median overall survival was significantly better with the combination of camrelizumab and rivaroxaban versus sorafenib. However, this study has much population, almost 80% population in the eastern region, and only around 20% population in the western region. So the other combination is lenvatinib with TACE or any other loco-regional therapy. So this combination of TACE and loco-regional therapy along with TKI is mainly attributed to one component of group in the new BCLC, which is a BCLC-B with diffuse infiltrative lesions where the TACE is unsuitable. So why the potential benefits of lenvatinib and TACE? Basically, with the addition of lenvatinib, the tumor vessel gets normalized and there's increased penetration of the drug. So based upon this, based on if you do the TACE alone, doing a palliative TACE, the response is minimal, and along with it, the recurrence and metastasis is higher. The proposed factor is a synergistic effect of lenvatinib followed by TACE. Is lenvatinib causes an increase in the sensitivity of TACE and increase in the drug penetration post TACE, and there's increased tumor response. There's limited deterioration of liver function, and the recurrence and metastasis are less. So there are few studies which are retrospective control study where 122 unresectable HCC patient TACE plus lenvatinib versus TACE has been seen. So overall survival rate and the progression-free survival are overall comparatively better with TACE alone when you TACE plus lenvatinib, and the duration of TACE, the requirement of TACE decreased when you add lenvatinib. So these are the proposal concepts where patients addition of lenvatinib suppresses the HCC growth, and you do RFS for multiple lesions, then which reduces the tumor blood flow. Then you again continue with the lenvatinib, and after follow-up, if there are lesions, they can do a multiple sessions of RFS. If there are large lesions, the proposed concept is to do RFA or SBRT followed by lenvatinib. So this is a pilot study. It's a proposal concept where combination of lenvatinib and radiofrequency ablation for patients with intermediate stage HCC, which are beyond to 7 criteria. There are multiple lesions which are there. So the real world data which is shown that only around 9 and 13 patients, around 21 patients which are taken, and it's been shown that the median overall survival and median progression-free survival was better with the combination of lenvatinib and radiofrequency ablation rather than lenvatinib alone. So the other trial is the combination of lenvatinib and TACE, which is a launch trial, is a randomized control trial. So this trial, which had 168 patients in each arm, randomized 1:1. And in this patient also, you can see that the combination of lenvatinib and TACE, when compared to lenvatinib alone, has a higher objective survival response rate and a disease control rate. The overall survival was significantly higher with the combination of TACE and lenvatinib rather than lenvatinib alone. So conclusion which was drawn from the launch trial was lenvatinib plus TACE was safe and effective for patients with advanced HCC with acceptable toxicity, and it as a potential new first-line treatment for patients with advanced HCC can be considered. So these are the other first-line what are the first-line for undissected HCC, or the systemic treatment options. The latest being the case 310, which showed a positive for overall survival only. The other key trials for TK on second line, which are the previous trial, no other TK has been approved as the second line recently, and these are all the cabozantinib, regorafenib, and ramucirumab, and these are the old second line drugs. So we conclude the talk saying that TK had shown effectiveness as first line as well as second line treatment, and it's most likely to have better efficacy and tolerability compared to sorafenib. And lenvatinib plus TACE combination appears to be a good downstream strategy for advanced HCC patients. Combination therapy of TK and immune checkpoint inhibitor, it's a new area, and patient selection is an important criteria. But overall, the patient's performance status, underlying liver condition, other comorbidities, and along with cost-benefit ratio will be an important factor to determine the first-line therapy in our populations. Thank you. Which patients? Before TACE. So few patients, they said 1 week before TACE can be started, but the trials which have been done, they've started 1 month TACE, 1 month lenvatinib, followed by 3 days they've given TK free period before TACE. And post TACE, after 3 days, they've restarted the TKI.
Out of how many patients you have given lenvatinib, how many responses you have seen like this? He said, yeah, he said given an excellent response, I agree. Out of how many patients you have treated lenvatinib and you have seen this response compared to patients who have treated atezolizumab and seen this response?
So I've not compared atezolizumab and lenvatinib, but this is one patient, few patients who have responded. with
Are
lenvatinib.
you sure that there was a tumor thrombosis? It was a bland thrombosis?
It was a tumor. It's an expansile thrombosis which is there. It was a
It's
tumor
interesting
thrombosis.
because once we see that tumor thrombosis is there, the response is not, I mean, this patient is lucky, I would say, in that sense. So thank you, Shantan. And now we move to the next talk, myths and facts.
And I just want to say first, I feel bad for you. I think Anand fed you to the wolves in terms of giving you this talk. So I think he set you up to make himself look good for the next talk. That was, I think, the first thing that I'd say. So I will say two things. I think that, and I think Anand's going to address the non-viral, viral stuff in his talk. So I'm not going to address that now, but I think it's a misconception in general. And so I'm going to let him talk about this during the myths in terms of this whole viral versus non-viral thing.
Right.
The second thing that I'd just say is I think we should caution with these cross-trial comparisons. So, you showed, the comparison of the lenvatinib arm from LEAP-002, and you're comparing this to atezobev, and you're saying, oh, the median survival looks similar. But we have to remember there's very different patient populations. So the MGrade 150 was the only trial that included patients with VP4,
Right.
a significantly negative prognostic factor. Those patients were excluded from LEAP-002. So automatically, both of those arms are going to look better because you've selected these patients that look very good. Same thing when you took a look at the AFP low group, very big prognostic factor. So when you take a look and you say lenvatinib has a very good survival compared to atezobev, I think these comparisons, it looks very good when you compare lenvatinib to this, but at the end of the day, the comparison against lenvatinib versus sorafenib showed non-inferiority. Atezobev showed superiority. And I think that we have to go with the data we have. And I think these data, retrospective, et cetera, I think we have to sort of say these are indirect comparisons. They're imperfect. There's residual confounding. And I think and I'm sure Anand will go over this in his talk, and I'll sort of do the same. I think at the end of the day, we have to take the data for what the data are. And atezobev has been shown to be superior and should be the preferred agent. I think likewise, if you had a patient who could afford both, I would
Definitely
be
would have
surprised if you'd be like, oh, you can afford both, and I'm still going to provide you lenvatinib. I don't think anyone here would do that.
Correct.
Whether they have NASH or viral or whatever, I think all of us in our heart of heart believe
No, that was
that
the
it has
first
a better.
option which was
But I feel
given.
bad for
Yeah,
you.
yeah.
I think Anand made you argue this side by giving you the talk. So that's why I
Right.
said what I said up front.
Right,
But I think that just when we talk about it, I think that walking away, being assigned something, I think we have to walk away with understanding the data are superiority for atezobev.
Actually, I saw this patient in OPD. No
Okay.
tumor at all.
Right.
There's
Correct.
just a bland thrombosis. I
Bland
was
thrombosis.
wondering what to do. He is actually.
He's doing well.
He's doing well.
Yeah.
But he's got some. He's able to take the.
Lenvatinib. Yeah, yes,
He's
complete.
just taking like once in a.
That's it.
3. So.
Continue.
Transplant or not? There's nothing. He's not.
He's not decompensated. It's compensated. Good performance.
Now we will, because now Karni is going to talk about myths and facts, immunotherapy. Naveen, okay, so we'll have more discussion because we have plenty of time. So about this for discussion. So myths and facts first. Immunotherapy in HCC. Anand.
I will counter Shantan in the next few slides. And I would like to thank, this is myths and facts of immunotherapy in HCC. I'm really thankful to my colleagues, friends, and residents who helped me prepare these slides. I sent them a question: what is your first opinion on immunotherapy in HCC? They give excellent answers, which became, some of them are myths, some of them are facts, and I will try to address them in the next few slides. So immunotherapy, the first question I sent, the first answer was it's an upcoming modality. Not upcoming modality. The first immunotherapy approved by FDA was BCG for bladder cancer in 1990. It's not upcoming treatment at all. Rituximab in 1997 for NHL, trastuzumab for breast, bevacizumab for glioblastoma multiforme in 2004. It's been there for a pretty long time. So immunotherapy is just you boost your immune system and then you kill the cancer cells. That's what is called as immunotherapy. So atezobev came in 2020 for HCC. So BCG was the first immunotherapy which was approved for bladder cancer. It's not upcoming modality, it's a standard of care, especially for HCC. It is recommended first line therapy by INASIL ASLD, BCLC, ESMO, NCCN, you name the guidelines, all the guidelines have immunotherapy as the first line drug. Atezolizumab, if the patient has high risk of bleeding, then probably Durvat plus Tremi, which is not yet available in India. We are more well versed with using atezolizumab, and I'll be probably talking more about atezolizumab in my slides. The second one was, I don't know what is immunotherapy. I don't know these, and probably the immune checkpoint inhibitors are only expressed in cancer cells. I'm not sure what they are. This is the second answer which came to me. Fact, no, it's not expressed only by cancer cells. It's a natural immunity of an individual, and cancer cells just take the advantage of this and develop resistance to the tumor, to the drug. Sorry, to the immune system, which is then targeted by immunotherapy. We enhance the immunity of the individual, whereby we kill the cancer. Also, in the meantime, the patient may have other autoimmune disorders which may flare with these drugs. We should be thankful to these two individuals who got Nobel Prize in 2018 for identifying these molecules, that is CTLA4, James P. Allison, and Tasuku Honjo, who identified this way back in 1992. So it's two pretty long, it's been decades that we have found these, and we have just honored them with Nobel Prize in 2018. We also have the photo of these individuals in our Nobel Prize lane in our hospital as well. So my myth is second, the commonest myth everybody says is the aim in HCC is only palliative. Be the drugs, it's always palliative. It's not palliative. The aim has now moved to probably more towards curative treatment for these patients. What is palliative? Yes, I agree. It's palliative more often. We just prolong the survival and keep the disease-free patients. It's most often in PCLC B and C. Definitely possible. Very good data for these patients. Neoadjuvant, there is some data that acts as a bridge to the patients to achieve a curative therapy and achieve complete pathologic response. There is some possible data which is coming up. There is also data from AIG on this as well. Adjuvant therapy, which is you do a curative therapy, you do a resection, then you offer these patients with immunotherapy and enhance the survival, prevent the recurrence-free survival. There is no but data, IMBRAVE 050, which said that it reduces the risk of recurrence, but the overall survival data is still yet to come out. But yes, there is the aim has moved from palliative to keep a patient from cancer and drug-free as well. This is a beautiful article in Liver Cancer by Kudo, where he says that you combine atezolizumab for patients who are untraceable, that is advanced disease, you start them on atezolizumab. You can achieve cure. You can stain them to tear a tumor. You can reduce the number of lesions. You can also treat them by curative resections or RFA or surgery or transplant later on. So the aim has moved from being palliative to curative surgery, curative therapies for HCC. And that is only possible with the use of immunotherapy. Unless 1 or 2% of patients who may respond to your TKIs, I would be probably more favoring immunotherapy. The second thing was it is not probably suitable for elderly population. Only young population, it's quite suitable. There are certain studies which have been done. This is a retrospective study of large population which said that be it less than 65 or more than 65, the response remains very good. Immunotherapy works very well for these patients. There is no difference in overall survival or progression-free survival. This is the similar study which was published in liver cancer. It's a subgroup analysis of IMBRAVE 150, where they showed that even in patients with age more than 75 years, they have excellent response. Be it less than 65, 65 to 75, more than 75, they have excellent response to immunotherapy. They have excellent overall survival and progression-free survival. This is the conclusion of that study, which I read here. Across all age groups, patients receiving atezolizumab had longer median overall survival, and the hazard ratio was less than 1. So compared to in patients who are less than 65, 65 to 75, and more than 75. So it's excellent across all ages. It works for, next I will talk about etiology as well, but across all ages it works very well. So again, as I said, many students replied me that it's a palliative measure. I won't be doing anything for these patients. So this is from the IMBRAVE 150, there where they showed that 10% of patients, for treating 100 patients, 10 patients will achieve complete resolution of tumor. That is sufficient for us to achieve a cure for these patients and offer a curative therapy just like the previous patient. So if compared to 1% or 0 to 1% in the other group, there is 10% of patients who can achieve a complete response. Almost disease control rate is 72%. Objective response rate, that is combination of complete response and partial response, up to 35%. That is up to 45% of patients can be offered a curative surgery later on if they receive this drug. The survival is very few months. That was the myth which most of them also replied. This was the previous BCLC in which they said that only 10 months is the survival with systemic therapy. But you see the recent updated BCLC and the ASLD guidelines, both of them say that with the current available systemic therapy, the survival is more than 2 years. Also shown in the previous slides by Dr. Shantan as well. The survival is more than 2 years for with these drugs. So it's not palliative, it's curative. For you, 2 years may be small, but for patient and his family, 2 years is pretty huge. The patient who has a huge HCC burden. Long-term survival as well. This is 2 studies, one from our center where we showed that patients who receive child patients who receive atezolizumab, they have excellent survival. The survival is almost 21 months. Today, I saw a patient who has come after 17 doses of immunotherapy, still doing okay, and is absolutely happy. He doesn't want transplant. He says, I'm okay taking the injections. Why do you want to do me a transplant? The second, on the left side, we have the right, that is combination of durvalumab and tremelimumab. Also shows that survival at 4 years is good, excellent, almost 30% survival till 4 years in this study. Long-term survival is there with immunotherapy, but probably less frequently in other drugs. Etiology. This is one of the common myths which was discussed in the previous speaker. I agree with his slides which he showed. This was 2020 which he showed. The meta-analysis also was in 2021. The updated meta-analysis has been brushed away by Shantan, which I'll be showing over here. So what they initially said in Nature was, in the Hepatology, this was the 2019 article, there they showed that NASH patients have stronger response. CTLA4 infiltration are more common in NASH, while PD1 infiltration, CD8 infiltration is more common in patients with, and PDL1 expression is more common in patients with HBV. So PDL1 patients usually, anti-PDL1 works well for viral marker, viral hepatitis, viral HCC, and while CTLA4 other will work more for NASH patients. This was the actual thing which was said in this article in Hepatology. Similarly, this was the one which he showed that NASH limits the surveillance, anti-tumor surveillance immunotherapy treated HCC. So more probably PDL1 expression in HBV and less in NASH. That's the reason it may not work. This was the proposed hypothesis. But there is a problem with these studies. They only gave PDL1, anti-PDL1. We never said give anti-PDL1 alone. We said it's a combination of PDL1 and VEGF inhibitor. The initial study, which was published in Lancet Onco on GS03, the number I don't remember, is also said that anti-PDL1 will not work alone. It's a combination of these 2 drugs which will work better for these patients. And diagnosis of pure NASH, as said by Dr. P.N. Rao in his first talk, that is very difficult. Overlap of alcohol is there, other diseases is common. So pure NASH is impossible. You are showing a preclinical model and saying that PDL1 doesn't work. I don't agree with that. This is the article. This is a conclusion I have taken from Kudo's article in one of his journals, Lack of Response to Immunotherapy in NASH-related HCC. This he published after seeing that Nature article. He concludes that clinical diagnosis of NASH alone and not administering atezolizumab may be disadvantageous to the patients. Therefore, it is important to initiate treatment with atezolizumab and switch to second-line treatment immediately after it is found ineffective. What is immediately? I will be telling in the next few slides. This was the updated meta-analysis published in the Journal of Hepatology by Tim Mayer. There's a huge name in oncology as well, HCC as well. He said that in respect to all, he compared all the recent RCTs and said there is no role of etiology in the immunotherapy at all. And we also published from our group, which Amit Singh also led this meta-analysis, was published in Lancet's group, Lancet article journal. The objective response rate, disease control rate, progression-free survival is comparable between viral and non-viral. So I don't agree that the disease etiology matters. What matters is patient. You have to treat the patient with immunotherapy if he is fitting the criteria for atezolizumab. This was one of the students who replied that it should be given only for BCLCC. It's not that so. It is the IM Brave 150. You can give for A, B, and C all the stages, but preferably give to the patient who has good CTP score and good performance status. BCLC till C you can give them. BCLC-D probably nothing much. The next, this is immunotherapy cannot work in patients with high tumor burden extrahepatic spread, which was shown in the previous patient. He had only puerperal and thrombosis. This is the IM Brave subgroup analysis where they showed the patients who had macrovascular invasion and extrahepatic spread, they had better overall survival and progression-free survival compared to those who received only TKIs in this subgroup analysis of these patients. And for to also say further that we have also treated this patient. This patient was had gone to some big hospital in somewhere in north, and he came to us saying that he was given a certificate that you will not respond well, you may go home. It's just given sorafenib. I told him that you can start with this patient, start with atezolizumab, we'll see what happens. I'm not sure what will happen. His AFP was more than 10,000, it was 46,000 to be precise. We started him, this is a Lamar's which is seen over here. He had pelvic mets, bone mets, large tumor burden. After 6 doses, this is his picture. The tumor has gone, there is no bone mets, nothing. His AFP is currently around 912. Nothing else to be done. He has excellent response with 6 doses of immunotherapy. What else is required? He's still doing better now. The third thing is whether immunotherapy works only for liver. This is a recent study. There are some PDL inhibitors which work more for lung, but for compared in HCC group, most of this response is much better in patients in lymph nodes, liver, and then lung. Other organs, yes, but what we see in our clinical practice is adrenals don't respond that well for patients with atezolizumab. But other organs, lymph node, if the patient has lymph node or mets, yes, it works very well. The third, next myth is we need to continue atezolizumab for lifelong for all. Quite difficult. So these are the studies which have showed that I agree that it should be continued for longer period, but most of the studies have given for 6 doses, a median cycle of 6 doses. And what the initial article which was published in Lancet Onco said that 80% of patients treated with atezolizumab achieve 30% response, that is complete response or partial response, within 4 doses, and another 20% by 2 doses. That is 6 doses, we understand that the patient is responding or not. If he is not responding, discontinue therapy. There is nothing much to worry, but you can give at least for 6 doses and check the analysis assessment. The risk of vessel bleeding is high with atezolizumab, and there is no clarity of management of patients' high-risk varices, which was the question by few of the residents. The risk of bleeding is 4.7%. Bevacizumab is available since 2004. So we are just worried about bleeding in our patients with HCC. It is similar between child A and B. The risk is only higher in patients who have more main portal vein thrombosis, but otherwise it remains same. You can give a beta blocker or do a banding. What ASLD says, I will be telling in the next few slides. But bevacizumab, which has been available for a long time, bleeding is an unusual but fatal side effect, and treat with carvedilol, propranolol, and EVL for these patients. So this is the ASLD guidelines for students who have been there. They asked me, what should we do? I'm not understanding. So patients considered for atezolizumab should undergo EGD. That's absolute. There is no doubt in that. Second thing, the optimal treatment for large varices is unknown, although ASLD recommends at least 1 session of banding, and carvedilol may be considered as an alternative management of varices prior to atezolizumab. We have the main author over here. You can ask your questions as well. Patients with recent GI bleed within 6 months and those with high-risk stigmata for bleeding on AGD should have varices adequately treated prior to atezolizumab, or these patients may be considered for other therapy, that is durvalumab. So all patients should undergo endoscopy. If the patient has high-risk varices, avoid or eradicate, then start the treatment. If the patient has recent history of bleed, then avoid as much as possible. There is also a study in Liver International which said that patients with a past history of bleed have high risk of bleeding. We can also reduce the dose of bevacizumab. What we usually do is start at 400 mg and then increase up to 10 mg per kg body weight, and prescribe beta blockers and simvastatin for these patients. And PVT, if the patient has main portal vein thrombosis, I would usually avoid EVL because the risk of bleeding from the ulcers are pretty high for this patient. That is my experience. I'm open to thoughts. The autoimmune hepatitis is also common in this patient. The commonest drug which we are not using actually is ipilimumab plus nivolumab, which has highest risk of AIH. We can treat these patients with corticosteroids with or without mycophenolate mofetil. So it's a treatable adverse event because some of them replied saying that side effects of these drugs are more and are not manageable. I agree that side effects are pretty high, but they are usually manageable. You cannot perform transplant after immunotherapy. Yes, you can perform transplant after immunotherapy. There is strong data regarding nivolumab. There are multiple studies on nivolumab. There are also data which is coming up on atezolizumab and bevacizumab. You can do transplant. These are some of the studies, and this is our experience with transplant after atezolizumab. 10% of patients downstage with atezolizumab. Good number. BCLC B, C5 and 7 had 4 patients had undergone local therapy. 3 died on wait list. 3 are still waiting. One more patient has already undergone transplant. The poor LDLT is 1 DDLT, 1 resection following atezolizumab. Time to transplant is around 80 days. The problem with, we also did some liquid biopsy and found that patients who underwent transplant had very low tumor mutational burden and negative for any microsatellite instability. None of the patients had AFE more than 400, and after around 10 months of follow-up, they haven't only had only one mortality because of some other complications. But these patients who receive bevacizumab are higher risk of wound complications. So transplant is possible. Coming to the last last two slides. So you can infuse immunotherapy at any time of the day. This is a recent study which I felt very interesting. This is 13 studies. It's a meta-analysis. What they found out is patients who received immunotherapy before 2 o'clock in the morning had better immune response compared to those who received immunotherapy in the evening times. I was wondering what is the reason for this. In fact, this was given a Nobel Prize for this patient. I'm afraid you should understand why this is so. The circadian rhythm and the ICIs. If you see here, pro-inflammatory cytokines circulate at higher levels during the rest and at night, whereas anti-inflammatory do so during the daytime. We all know that glucocorticoid levels, potent immunosuppressants, peaks at the beginning of the day and reaches its lowest level in the first half of the night. And CD8 cells, coming to cellular immunity, are also subject to circadian variations, with notably more intense proliferation during early afternoon and circulation of B lymphocytes in the end of the evening, but CD4 helper cells in the night. So CD8 are more active in the morning. You give immunotherapy in the morning hours. I'm not sure how much the medical oncologists will agree with me, but this I found very interesting because you can schedule the patient to give immunotherapy early morning and he probably will have a better response. This has also been found for BCG vaccination, influenza vaccination, COVID-19 vaccine as well. Early morning vaccination will improve the immunity of these patients. And these individuals have received a year before our PD-L1 inhibitors discoverers received. They already received the Nobel Prize for this identifying this gene, how circadian rhythm is modulated in our system. They identified a protein called as PER, and they were given Nobel Prize in 2017. So for ideal candidate for immunotherapy, good performance status, BCLC B or C, child up to 7 or maximum 8, bilirubin must be less than 3 unless it is indirect hyperbilirubinemia. Age, etiology, tumor burden may probably not related. Rule out autoimmune diseases, there is no doubt in that. Evaluate for varices. Beta blocker plus mirastatin is must. For ramucirumab, which I didn't discuss over here, because the initial study did not find any effect in these patients. They found that patients who have higher VEGF expression, that is higher alpha fetoprotein, they respond better to these drugs. To summarize, complete response is not uncommon with immunotherapy. It has excellent overall survival. It can also act as a bridge to transplant or also downstaging. But the problem is it's not economical, not easily available, and there are certain unusual adverse events we should be aware of. I'd like to thank everybody. If there are any questions, Dr. Amit is here to support me.
I think excellent review, Anand, and you have addressed several myths about immunotherapy in the management of HCC. Now we move on to the next talk, that is liquid biopsy in HCC. Is it worth the effort? And to deliver this talk, we have Dr. Vamsi Krishna. Dr. Vamsi, please. I think after these talks, we will have a panel discussion and we can address all the issues. I will ask our fellows if any doubt or any questions, please raise these questions during that.
Good evening, everyone. Thanks, Dr. Anand, for having me here and giving me an interesting topic. This is slightly off the path from all the glamour of the immunotherapy, but it's an interesting topic for me. So I was asked to speak on hepatocellular carcinoma liquid biopsy. Is it worth the effort? And for me, fundamentally, whenever you ask, is it worth the effort? It sometimes takes me back to think of, are we doing anything just because it is not worth it? Or should we continue doing something even if we don't see the value in doing it right now? It reminds me of these two famous gentlemen. I don't know how many of you recognize them. Anyone in the hall recognizes those two? That's Tenzing Norgay and Edmund Hillary, who were the first people to climb Mount Everest. Now, more importantly, before them is what George Mallory from New Zealand said. In 1924, he attempted an unoxygen-supported climb of the Everest. And when he was asked, why are you doing it? He said, because it is there. So sometimes you have to do things even if they don't seem worth it, even if you feel it cannot be done. And that's the reason why liquid biopsy is really coming into picture nowadays and what we are doing. Obviously, we cannot we do have to look at whether there is something that has any benefit. We need to look at the cost. We need to look at what liquid biopsy is right now. So I'll just cover these 2-3 points as to what exactly is a liquid biopsy, what can we do with it in HCC, and what is the status today. Now, this is often asked by a lot of non-oncologists and even among some oncology colleagues that, okay, why don't we do a liquid biopsy? And my answer is, okay, fine, liquid biopsy, you want to do. What do you want to do? And I am met with blank stares. The reason is, see, liquid is nothing but blood. Biopsy is nothing but testing. Now, what do you want to test in the blood is what your testing is all going to be all about. You could test for something like just the cells, which are known as the circulating tumor cells. The technology is different. What you can find in the CTC is different. You could test for something known as exosomes. Now, exosomes or EVs, they are known as the extracellular vehicles. They are basically large structures which include cellular particles and DNA particles. You could look for just the tumor-derived platelets. Even that is something being tested. Or you could look for the cell-free nucleic acids, which could be DNA, which could be RNA. Now remember, when you say liquid biopsy, it covers the entire spectrum of all of this. And depending on what you want to test, you're going to test for something. So again, a lesson for everyone, do not just say, I want to do liquid biopsy. Tell what you want to do in the liquid biopsy. It's like saying we just want to do a test. What is the test? What is it for? You need to specify. The most important part which we look at is known as circulating tumor DNA. What are the applications of a circulating tumor DNA? A circulating tumor DNA basically is a DNA that is shed from the tumor into the blood. This is part of the circulating free DNA. Now, cell-free DNA is a full composite of all the things which cells shed. Among that, whatever the tumor is shedding, that's the ctDNA. So you need to identify the ctDNA. You can do something like a tumor genotyping on it. You can monitor tumor burden. If you're given some treatment and you want to see, is it responding? Rather than a scan, you can just look at the amount of ctDNA that has a correlation. You can look for minimal residual disease where your scan is not picking up anything, but you still might have some tumor inside. So these are some applications of a ctDNA. Coming to the other application where you want to do a genotyping of the tumor, you need to see what the tumor mutations are. So there you can either do a solid biopsy or you can do a liquid biopsy. What is the advantage of a liquid biopsy? All the tumors all over will shed your tumor DNA and you can capture all of that in a single draw. So you are accounting for the tumor heterogeneity, which is not always possible with a solid biopsy because a solid biopsy is done only from one part. Other benefit of a liquid biopsy, you can keep doing it. How many of our patients will agree to repeated tumor biopsies? We push them for it. That's a different issue, but still, not all patients are ready for it. So you can do that as well and get a sense of the dynamic change in the tumor DNA. So that is what a liquid biopsy can do. So my topic is about HCC. It's not about liquid biopsy. Let me come to HCC. Specifically in HCC, what all can we do with a liquid biopsy? And contrary to what many may think, it's not just in the bottom part where you have a HCC. The benefit starts on the top. When you have a cirrhosis patient, you want to surveil the patient for potential future development of cancer. There are a lot of tests available. There are serum biomarkers available. There are combination models available. This is one place. If you could detect certain changes in the ctDNA, which could herald the development of a tumor or which could diagnose a tumor early, that's a very important role where ctDNA has actually shown some benefit. Secondly, you have a tumor, you remove it or you transplant the liver. Can we then check whether the patient is getting the cancer back early or is the patient at a higher risk for developing a cancer? Again, that's something which you can do with this liquid biopsy. You can test for the ctDNA. The presence of ctDNA post-surgery still in the blood is actually a poor prognostic marker. And it is one of the markers which tells you that a cancer can develop later. Whether by giving chemotherapy or immuno at this point, you can prevent it from happening, that's subject for research, but that's where the thought process is. It helps in prognostication. We often get patients, oh, you have done a surgery, now you're fine. You're not fine. You might still get a cancer back. Can I say you will get a cancer back? Okay, these are your characteristics. Let's do a liquid biopsy. It's positive. Okay, you are at a higher chance of getting the cancer. That's what we counsel the patient. Not a panacea, but it is something that helps guide prognostication. Then, of course, you have an intermediate or an advanced stage where you usually don't do a tissue biopsy. So this is a topic of debate. As oncologists, we are completely attuned to doing biopsies. In HCC, we don't. And this discussion we often have in medical oncology forums where someone says, oh, I do a biopsy in 80% of cases. And we say, oh, dude, we don't do it in 90% of cases. Our radiologists are so good that they are able to identify HCC. You don't really need it. This debate goes on. One of the ways you can get your treatment modalities, whether you can identify those mutations, is by liquid biopsy, and the technology is only improving. So the first thing that I told you, surveillance. Now that is somewhere where actually liquid biopsy is showing benefit. This is one test, OncoGuard liquid biopsy. Now this is not available for us. It's available in the US. And there's a validation done with our speaker as well, our eminent faculty being part of this paper, which showed that what they did was they looked at patients who had cirrhosis as well as patients who had HCC, did the ROCs, and found that doing the OncoGuard, a liquid biopsy, which not only looked at the tumor DNA, but more importantly, looked at the methylation pattern. So this is something we now know. You need to look at epigenomics. You don't just need to look at the DNA, you need to look at the methylation patterns. And that detected cancer better than just doing a surveillance with the test or doing the Galad score. So this was compared to the Galad score in this study. Now, this was a small study, but the phase 3 ALTUS is being done. And hopefully we'll have a report ahead. Beyond this OncoGuard, there are several such things which are available. A few of them have got FDA designation. And again, will I do it tomorrow? Possibly not. But is this something if a patient comes and asks me that, look, I'm very worried. Can this test help? You would say, why not? You can do the test. It may help you. Why am I still being a little hesitant and on the fence? Most importantly, because a liquid biopsy has certain limitations. Cost is, of course, there. You need good technology and very good bioinformatics. The bioinformatics to analyze and appreciate a liquid biopsy result is not available everywhere. And this is also why if somebody comes and tells me tomorrow in my clinic that, hey, I'm doing a liquid biopsy, please send me a patient. I don't, because I want to know what bioinformatics they're using. I want to know what is their validation. How many samples have they checked it with? And I can tell you half the labs which come are fly by night and they don't have answers to these. And that's why we don't do a liquid biopsy in every patient. And typically, India being India, you get someone who comes and says, oh, I'll do it at 10% the cost of what it is outside. Cost is there for a reason. Sometimes you need to spend money to get the quality and the reassurance that your reports are correct. So do not rely on every liquid biopsy, but it is important. What else can we do? This is about the early surveillance. I spoke to you about CTCs and prognostic markers. Now, CTCs are emerging as a good prognostic marker. How do you identify these CTCs? That's the biggest challenge we have. The commonest way to do it is using this marker known as EpCAM, and EpCAM positive CTCs in HCC are found in around 30 to 40% of cases. Again, what do you do with it? What is the cutoff? Tough call. Various studies have used cutoff. Somewhere around 2 per 7.5 ml is an average study in some studies. If CTCs are there, it indicates a poorer prognosis. If CTCs are not there, it's a better prognosis. Quantifying it, which is the best method of selection, you have plenty of methods. You can use immunochromographic methods, you have magnetic methods, you have bead methods. So it's a bit complicated, but again, a lot of studies have been done. The challenge is none of them are large, randomized, phase 3, 3,000, 4,000 patient data. Most of these are small studies. I don't think any of you can go through it. They're basically small studies. Again, a lot done in the Eastern populations, China, Korea, Japan. I saw one small study which was actually done in India. I couldn't get the final paper out of it, but they also tried to look at using CTC and using exosomes to identify whether there is a prognosis. So that's about how you can prognosticate. What about personalized cancer therapy? This is the holy grail of cancer right now. We want to identify patients, do a molecular profiling, find out those mutations in each patient, and then give drugs accordingly. In lung cancer, it is done. We are very comfortable with it. We have 30 to 40% of patients with lung cancer mutations, and we offer treatments accordingly. So much so that we tell a patient, hey, look, you're not symptomatic. Wait for 2 weeks. Nothing will happen. Let's get your molecular test before we start therapy. So in HCC, can we do that? The results are slightly mixed. What we know is that most common pathways involved in HCC are actually the Wnt pathway, the TERT promoter pathway, the P53, and the CTNNB. So there's the CDKN. Now, I don't know how many of the residents actually noted Dr. Anand's presentation. He showed you the liquid biopsy in his patient. One had a TERT, one had a P53. Those are the commonest you're going to see. Do we have a TERT promoter drug? We don't. Do we have something that can target the P53? As of now, no. Trials are ongoing. There are complex drugs. It's very complicated, toxic drugs, which are the P53 mutant, but it's something that we can look for. Now, what is the advantage of knowing this? If I do a liquid biopsy, I find somebody has a TERT. Patient goes for a transplant. Later on, I can start monitoring an MRD on the basis of the TERT. That's one of the ways we can look for. Does the patient have a TERT in the blood? Maybe that indicates that the cancer is coming back. Or we look at the levels of the TERT following therapy and we know that it is responding. These are not completely theoretical, by the way. All this is being done in research phases, not in a daily clinic, but this can be done. Beyond this, there are some pan-tumor biomarkers, and this is where something I have to confess is a little bit disappointing. You have BRAF, you have NTRK, you have RET fusions, you have the TMB, that is tumor mutation burden, or an MSI. Now, MSI high in liver cancer, HCC, is very low. If it is MSI high, it's probably a mixed cholangio or a cholangio. It's not a HCC. So, doing a routine MSI in a HCC biopsy is not required. If someone asks from anywhere, please tell them that, look, it's not really going to help me in a pure HCC. A TMB, the TMB story has been ongoing for 5 years. We are not really clear whether TMB is actually benefiting in most cancers, and so we are not doing it. TDXD is a new drug which is coming for HER2 positive. Again, common in a cholangio, not so much in HCC. So these are drugs which sound very nice, in HCC, not so. So what else can we do? This is where the trials are going to go. You are not just going to look at early detection, you're trying to look at disease monitoring. You're going to try and look for patients who are relapsing early. You're trying to look for patients who are going to get the disease back. So take home messages from my point. It's not ready for prime clinical time. Am I going to go tomorrow morning and order a liquid biopsy for patients? No, that's not going to happen right now. The data is maturing. Best use, I feel, is going to come in early detection. Disease monitoring is somewhere where we are going to use. In India, we have a unique problem. We don't know what are the mutations to be checked. We don't have that much data. In India, the treatment and the doctor's fees and doctor's treatment is significantly cheaper than the tests. So that's one thing. An ultrasound abdomen in India costs significantly lesser than what I believe it costs in the US. So there a blood test still makes sense. In India, it's not there. So we need to bring down the price. It's happening. Already the cost of a mutation analysis, 200 gene analysis, which was 1 lakh before, is now 15,000 or 20,000. So costs are coming down. It will come down. Most importantly, we need to establish a genomic profile among our patients. And I think that's where we should do. Again, when we have these meetings, we get a rush of excitement and say, oh, tomorrow I'm writing a protocol. But as a research lab knows, our protocols are few and far in between. It never comes out of the brain onto a paper. So that's what we should do. As Robert Frost said, the woods are deep, dark, and lovely, but we have miles to go before we can see. Thank you.
I think thank you, Dr. Vamsi, and we will take up questions at the end of the session. And now I invite Dr. Amit Singhal to deliver his talk. This is basically the most anticipated talk of this evening, and he's going to talk about evolution of systemic therapy in HCC, role of immunotherapy. I would like to take this opportunity to welcome Dr. Rajesh Kota from Vijayawada, Dr. Deepak from Rajahmundry, and Dr. Shilpa from Vizag. Welcome, doctors, to participate in this symposium. And Dr. Amit is actually professor of hepatology from University of Texas, and he has special interest in HCC, and he was co-chair in drafting the guidelines for management of HCC by ASLD. Dr. Amit, the stage is yours.
So thank you so much for the invitation. I'm excited to be here. It's been an excellent symposium so far. As you heard, I'll be talking about the evolution of systemic therapy in HCC, role of immunotherapy. I think Dr. Anand covered many of these topics in his presentation in terms of the myths and facts of HCC treatment. And so I'm going to just sort of help build upon this in terms of going through this from where we are in today's landscape. Quite an exciting time when we've been treating these patients. Here you can see my disclosures, a disclaimer from Roche. So we've seen this slide already, the BCLC 2022 staging and treatment allocation system. I think, the couple points that I just want to highlight here is that the most important thing that we can try to do is to find these patients early when possible. If we find these patients at an early stage, we have curative therapies available: surgical resection, liver transplantation, local ablation. And these continue to be the therapies that give us a median survival over 5, if not over 10 years. I understand that because of limited screening implementation here in India, this is relatively uncommon at baseline. The one thing that we can now appreciate is that we see more and more patients having these robust responses. We saw this with the patient case initially with lenvatinib. I agree, relatively uncommon with lenvatinib, but it can happen. And we're going to see these patients more and more with immunotherapy. And I think the key thing is, even if patients don't present up front with early stage disease, you will see these patients who initially present with infiltrative disease, with vascular invasion, who have robust responses and are then downstaged to having minimal disease. And I think when that happens, the key thing is not to simply do a short visit and say, you're tolerating the therapy well, you're doing well, we see minimal disease, I'll see you back in a month. But instead to say, you have now been downstaged, should we consider surgical resection? Should we consider transplant? And those decisions are quite important. And those are the ways that we're going to really have the bar for survival continue to increase in the advanced stage setting. The other thing that you can see here over time is the bar for systemic therapy has only continued to get wider and wider. Once again, Dr. Anand showed the old BCLC, and it was a very narrow bar that said sorafenib had a short survival. And now you see the bar for systemic therapy not only sort of limited to those patients with advanced stage HCC, but also some patients with large intrahepatic disease now recommended to undergo systemic therapy. This allocation system was just updated in 2022, but one can argue it's already out of date, because now systemic therapy is being evaluated in the adjuvant setting. It's being evaluated in the combination setting. And what we will see over time is that systemic therapy will have the widest bar. It will cover the entire spectrum of HCC cases we see in clinical practice. As we already heard, the 2022 update now incorporates these new systemic therapy options. So the BCLC recommends atezobev and durvalumab as being the preferred agents whenever possible, with TKIs only recommended if patients are not eligible for those IO combinations. A slide we've seen previously shown from the AASLD guidelines in terms of the landscape for HCC treatments, moving from the TKIs, sorafenib and lenvatinib, and now having agents that have been shown to be superior in terms of survival. Atezobev in 2020, and then the combination of durvalumab and tremelimumab in 2022. Now, our transition from TKI therapy into immunotherapy was anything but smooth. I think all of us remember Checkmate 040. We saw durable responses in 15% of patients, and they were quite exciting. This is the first time that we saw responses that were not short-lived. They tended to last several months. And there was a lot of excitement that this may be the agent that could improve overall survival. However, when this was introduced in Checkmate 459 and compared to sorafenib, we saw that single-agent PD-1 failed to improve survival compared to sorafenib. And this is something that we now consistently see in trial after trial. Single-agent PD-1, single-agent PD-L1 is insufficient to improve survival compared to sorafenib. Saw this in Checkmate 459. We saw this in Rational 301 with tislelizumab, and we saw this in Himalaya with single-agent durvalumab. Single agents are not sufficient. We really need to move on to combinations. And so this really underlies why we look at the combinations of atezobev and the combination of durvalumab and tremelimumab. So first, atezobev is a PD-L1 plus a VEGF inhibitor. And our understanding of VEGF inhibition changed. It's not simply anti-angiogenic, but it's actually immunomodulatory. We saw some of this discussion earlier, where the VEGF pathway can decrease regulatory T cells, increase cytotoxic T lymphocytes, increase dendritic cell proliferation and maturation, decrease tumor-associated macrophages, and decrease myeloid-derived suppressor cells. By doing so, you prime the immune system, and by using this in combination with an immune checkpoint inhibitor, you increase responses, you improve overall survival. Likewise, we've taken a proven combination of an IO-IO, so a CTLA-4
plus a PD-L1 that has worked in other tumor types, and you now apply this combination to HCC. We know that the CTLA-4 mechanism acts earlier in the immune cascade. You increase T cell diversity, and the PD-L1 acts later in that cascade, keeps those T cells active, and thereby the combination can increase responses and improve survival. Now, we start, in terms of the evaluation of atezo-bev, started with this phase 1b study, comparing atezo monotherapy versus the combination of atezo-bev. And in this phase 1b study, we see that the combination of atezo-bev improved progression-free survival compared to atezolizumab monotherapy. And this was consistent across the examined subgroups. So really highlighting that this preclinical rationale translated into clinical benefits. And anyone who's treated HCC long enough knows that we've come up with very elegant preclinical rationale that falls flat on its face when you look at the phase 3 data. Perfect example is Cosmic, this combination of cabo-atezo. This was supposed to be the answer because of all the immunomodulatory effects of cabozantinib. But the preclinical rationale did not work. But here we start to see clinical data that highlight the preclinical rationale for atezo-bev translates into clinical benefits. So now we move into the phase 3 trial, the IMbrave 150, atezo-bev versus sorafenib. When we see the updated analysis that was published in 2022, atezo-bev significantly improved survival compared to sorafenib. The longest survival we've seen, the longest median survival we've seen with an approved agent in the first-line setting. Median survival in the updated analysis, 19.2 months versus 13.4 in sorafenib. And as I mentioned sort of during the Q&A, this is despite a broad patient selection, the only trial that has included patients with main portal vein invasion, a very difficult to treat patient population that has been excluded from many of the other, if not all of the other clinical trials. Further, we see improvements in progression-free survival, and we see high responses, 30% of patients having objective responses with atezo-bev, including 8% of patients with complete responses. And we've seen this in clinical practice, patients with metastatic disease that have a complete response, patients with VP3, VP4 who have a complete response. So this is a very potent and efficacious combination. We know that the combination of atezo-bev is well tolerated, significantly better preservation of quality of life, median time to deterioration of quality of life over 11 months versus only 3.5 months with sorafenib. When we take a look at the AE profile, atezo-bev was well tolerated. Most of the adverse events that were seen in the IMbrave 150 were actually mild in severity. Very few grade 3-4 AEs. And when you take a look at this, the most common was hypertension, relatively easy for us to treat in clinical practice. Now, as we heard from Dr. Anand, one of the concerns going into the IMbrave 150 trial was this concern of GI bleeding, right? You have a patient with cirrhosis, inherently higher risk of GI bleeding. You add in bevacizumab, which can also cause GI bleeding. And so there was a concern that this may actually cause high risk of GI bleeding. But when you take a look at this, the risk of GI bleeding in the IMbrave 150 trial, only 7% of patients, compared to 4.5% for those patients treated with sorafenib. Now, one of the key things here is that the patients all underwent an upper endoscopy within 6 months prior to randomization. So one of the key things here is careful patient selection. And if you select your patients well, this is a very well-tolerated regimen. And we'll talk about this later in the talk of how we can select our patients well and set ourselves up for success. Now, before we get to that, one of the questions is, okay, fine, it worked in the clinical trial. But many of the patients we see in clinical practice are not clinical trial patients, right? We get patients with mildly worse performance status. We get patients with Child-Pugh disease, et cetera. So how well does this work in clinical practice? The nice thing is that atezo-bev has now been on the market long enough that we now have real-world effectiveness data that gives us some insights of how this works in patients that walk into our clinical settings. Here we can see one such real-world effectiveness study, the AB-REAL study. This study included just under 300 patients, and patients were followed for a median follow-up of 10 months at the time of this publication. When you take a look at the KM curves, the KM curves are nearly overlapping, really suggesting that atezo-bev works as well in patients we see in clinical practice as it did in the clinical trial. The median survival seen in the AB-REAL study, 15.7 months, which is within the range of expectation for the median survival that was seen in the IMbrave 150 study of 19.2 months. The other thing that we can see that's important here is the tolerability of atezo-bev in real life appears similar to that was reported in the IMgrade 150 trial. Grade 3/4 treatment-related AEs, less than 24% of patients. Bleeding events, 8% of patients. Very similar to the data being reported in the IMgrade 150 trial. Now, one of the things that you've already heard that's consistently reported, one of the risk factors for GI bleeding is the presence of this portal vein tumor thrombus. And we're going to come back to this in terms of how you can start to think through minimizing your risk of GI bleeding when you're considering this regimen. Now, study that Anand already showed here. So these are data that were generated from here in terms of a retrospective cohort study of 67 patients. And I think I'm not going to repeat all the data here, but I think one of the other things that you can see here is that the survival that you observe with atezobev is also largely dependent on the underlying liver dysfunction. So when you have a patient and they have Child-Pugh A disease, you're going to get a median survival of 21 months, once again in line with the IMgrade 150 trial. When you take a look at patients who have worse liver dysfunction, Child-Pugh B, Child-Pugh C, this can be done. However, you have to understand that you're not going to get IMgrade 150 results, but you're going to get lower survival because these patients can die and will die of their underlying liver dysfunction. Treating the HCC doesn't change that underlying liver dysfunction. Further, you can see that when you take a look at the tolerability, you can see that there is increased risk of AEs, particularly when you get to the Child-Pugh C patients. And so I think it's just the type of thing where it doesn't mean you can't do it. It just means you have to think of the risk-benefit ratio and the cost effectiveness of doing this. And so when you counsel your patients, I think you have to go with these data in mind in terms of the expected outcomes in a Child-Pugh A versus B versus C. Here we can see a systematic review and meta-analysis that is ongoing and has recently been submitted that gives you pooled estimates now in terms of the survival that is expected at 6, 12, 18, and 24 months. And you can see here, when you take a look at the atezobev real-world effectiveness studies, the pooled estimate of survival at 12 months is around 65%. And when you take a look at 24 months, 39% of patients are alive at 24 months. So really suggesting, once again, in these real-world settings, nearly 40% of patients are going to survive longer than 2 years, highlighting the same point that Dr. Anand made, that this is really a potent combination that can really give you long-term survival, very different than the expectations that we have with TKI-based therapy. Now, I understand that one of the biggest barriers to atezobev in India is cost, and I don't think there's any way around this. I think the one thing that I can say is that there have been cost-effectiveness studies looking at atezobev, understanding that these studies typically use US assumptions, and so whether these apply to India, this is also something that we need to consider. But here we can see a Markov model using data from IMgrade 150, and atezobev demonstrated an improvement in quality-adjusted life years, as one knows, though it came at an increased cost. When one takes a look at the base model, this had an incremental cost-effectiveness ratio of 179,000 per quality-adjusted life year versus sorafenib. The authors then looked at sensitivity analyses, and if you reduce the cost of atezobev by 20 to 29%, then this meets cost effectiveness, whether that's at 150,000 per quality adjusted life year or $100,000 per quality adjusted life years. Well accepted metrics for cost effectiveness. Now, one has to remember, in India, there's actually good patient assistance programs, right? You actually get every other dose for free up to the sort of 6th dose, and then actually you get sort of, my understanding is, free medication after that. So you actually have more than a 50% reduction in the price of atezobev. So with this in mind, and that even doesn't take into account that you can get biosimilars for bevacizumab. So there is a way for you to have significant price reductions, and this would be cost effective versus TKI-based therapy. Now, once again, already referenced the fact that we have other combinations available. This was evaluated in the Himalaya trial, the combination of durvalumab plus tremelimumab. Now, in contrast to the other IO combinations like Ipi-Nivo, this is given differently. Tremelimumab is given as a single priming dose up front, durvalumab given thereafter. And what we can see in the Himalaya trial is that you have significant improvements in survival. Median survival is 16.4 versus 13.8, 22% improvement in overall survival. And as was brought up, this really highlights that these IO combinations not only can improve median survival, but can give you long-term survival. 3 years, updated analysis showing 4-year survival. Stride has been well tolerated, as shown in the Himalaya trial, grade 3-4 treatment-related AEs, about 25% of patients, leading to discontinuation in only about 8% of patients. Now, as mentioned earlier, I mean, we talked about sort of this whole idea of lenvatinib versus atezo-bev. The issue is we don't have direct comparative data, right? So we have lenvatinib being non-inferior to sorafenib. We have atezo-bev being superior to sorafenib. We have Stride being superior to sorafenib. We don't have direct comparative data, atezo-bev versus lenvatinib or atezo-bev versus Stride. And so we're forced to rely on these indirect, imperfect comparisons. Here we can see a network meta-analysis. When we take a look at this, atezo-bev had significantly better survival than lenvatinib in this network meta-analysis, hazard ratio of 0.63. Atezo-bev versus durvalumab had a hazard ratio of 0.74, although the difference failed to achieve statistical significance. Now, we heard before about the retrospective studies, propensity-weighted analyses, et cetera. These analyses are very elegant statistically, but we have to remember that even despite those adjustments, there's still channeling bias, there's treatment error biases, and there's residual confounding. So even though there's statistically well sort of thought out approaches to how to try to adjust for some of these differences, they're imperfect. And so I think you're still prone to coming up with incorrect conclusions when you do these indirect comparisons. And so that's why when I take a look at the data and I try to make these decisions, I still come to the fact that one showed superiority compared to the comparator and the other did not. Now, how do societies incorporate these data into their recommendations? So first, looking at a NASL. A NASL actually recommends atezo-bev as their preferred systemic therapy for patients that require systemic therapy. And then both sorafenib and lenvatinib can be considered if patients cannot receive immunotherapy. Now, of course, durvalumab and tremelimumab is still awaiting approval in India. Once approved, this would be an alternative preferred first-line therapy. So you really have IOs being the preferred first-line therapy whenever possible. And I think this parallels how we've recommended this from the AASLD perspective, and you can see this algorithm coming here. So when we see patients in clinical practice, the first question we ask ourselves, is this patient a candidate for immunotherapy? And outside of having liver transplantation, significant autoimmune disease, most patients are eligible for immunotherapy. So over 95% of patients in our clinical practice end up on immunotherapy if they're going to be started on a systemic agent. Now, if you're going down the immunotherapy route, the next question you ask yourself, is this patient eligible for bevacizumab? Do they have a high risk of GI bleeding, significant cardiovascular disease, significant proteinuria? And if the answer is they're not eligible for bevacizumab, then you can consider Stride when approved here in India. If they are eligible for Bev, then atezo-bev is a very good medication for this. Once again, very high responses, good survival. If somebody is not eligible for immunotherapy, that's really when sorafenib and lenvatinib play a major role. Now, as has been mentioned, it's important that we screen patients for varices prior to systemic therapy. It's important to remember that this is not an atezo-bev issue. Patients with cirrhosis and HCC inherently have a risk of GI bleeding. Whether you do atezo-bev or not, the patient should undergo an upper endoscopy to assess for varices. The Baveno guidelines actually don't accurately apply to patients with HCC. There's actually been publications that show that it is inaccurate. We're currently looking for non-invasive measures in terms of identifying patients with varices, but those currently do not exist. And so we're reliant on doing an upper endoscopy, whether you do atezo-bev, whether you do TKI, whether you do Stride. These patients should all undergo upper endoscopy. It's just really the bevacizumab, it just impacts timing in terms of doing this prior to systemic therapy initiation. As was mentioned, we have different options in terms of treating patients with varices, whether this is banding or beta blockers. There's no current sort of good guidance in terms of which one should be recommended. When we wrote the AASLD guidance, we thought that doing at least one banding for large varices was reasonable. I think this is one thing that we will have better data as we go along. Unfortunately, those data don't currently exist in terms of the optimal management. One could argue that banding, you do have a higher risk of bleeding because of banding ulcers for the first week after. And so if you want to start a patient quickly on atezo-bev, it may even be better just to do beta blockers and then start the patient on atezo-bev. Importantly, the presence of varices, whether small or large, are not a contraindication to atezo-bev. You're really looking instead for high-risk stigmata, whether that be red whale, cherry signs, nipple sign. I think those are the things that you're really looking for in terms of being high-risk stigmata. There were patients that came into the IMbrave 150 trial that actually had varices at baseline, whether small or large. And you can see this subgroup analysis here, where those patients with varices at baseline had a consistent benefit of atezo-bev compared to those patients without varices at baseline. So it's important that we don't simply exclude all patients with varices from this efficacious regimen. We also see, once again, patients with VP4 disease. So we can see here that atezo-bev did improve overall survival in both groups. However, the risk of GI bleeding appeared concentrated in those patients with main portal vein invasion. We know that main portal vein invasion increases portal hypertension and is an independent risk factor for GI bleeding. Once again, showed in the AV-REAL study, showed in the systematic review that was performed by Dr. Anand. So this is really, once again, a consistent factor that has been reported in the IMbrave 150 trial and now in real-world clinical practice. So the way that we use this in our practice is if somebody has main portal vein invasion and no varices, we feel comfortable. May as well, you can go ahead with atezo-bev. If somebody has varices but without main portal vein invasion, you can treat the varices, you can go ahead with atezo-bev. If somebody has main portal vein invasion and large varices, that's a patient that I would be concerned about, and I would consider alternate regimens in that patient. Once again, covered already in terms of this liver disease etiology argument. I think it's important to note that this was controversial. I think that largely this has been settled. And I think much like has been discussed, we do not use etiology to determine IO eligibility. There are now updated meta-analyses that show that these IO regimens appear equally efficacious in patients with viral and non-viral liver disease. Further, there's been a post-hoc analysis of the IMbrave 150 trial. So we went in and got the granular data from the clinical trial and took a look at those patients who were treated with atezo-bev and looked at their clinical outcomes stratified by liver disease etiology. And you can see from the figure, the curves are nearly overlapping. And it doesn't matter if you have NAFLD or ALD or hepatitis B or hepatitis C, the outcomes for these patients are largely similar when treated with atezo-bev. And so these data largely say that we should be treating these patients with IOs up front. Now, if we treat with atezo-bev or durvalumab, one of the questions that comes up is what do we use after? Because all the agents have been evaluated after sorafenib. I think right now, if we have a patient that goes on atezo-bev, we typically use either lenvatinib or we use ipi/nivo, which has still accelerated approval in the US. There are studies that are ongoing in terms of looking at other agent combinations that could be used. For example, the IMbrave 251 trial is looking at the combination of atezo plus lenvatinib after atezo-bev failure. So we will have further data in terms of guiding second-line treatments in the future. I want to end just with a few slides just talking about how these therapies are now diffusing into earlier lines of therapy, including early stage disease as well as intermediate stage disease. In the early stage disease, we've seen now data from IMbrave 050 looking at adjuvant atezo-bev in patients at high risk of recurrence. High risk defined by either large tumor size, multifocality, or pathologic features, including microvascular invasion or poor differentiation. And those patients who were treated with atezo-bev had significantly better recurrence-free survival compared to active surveillance. Now, critics of this trial will say that the curves converge later, raising the question, are you simply delaying recurrence instead of preventing it? I personally think this is just given this sort of the fact that this was at the first interim analysis, the median follow-up of the trial relatively short. We do expect updated data to be presented later this year. And I think with further maturity of the data, we're going to see the curves continue to separate over time. We've also heard about the use of immunotherapy prior to liver transplantation. We've seen this case series from Mount Sinai. There's also a recent publication also from China showing safety of immunotherapy prior to liver transplantation. And then Dr. Anand's case series as well showing safety of immunotherapy prior to liver transplantation. I think we have more and more data coming out for this. And I think the key thing here is not to say we should use it routinely, but if you have a patient who's on immunotherapy who has a robust response and is eligible for liver transplantation, that patient should be referred. This is not a contraindication to liver transplantation. Now moving quickly into the intermediate stage setting, we know that systemic therapy plays a role in patients who have taste failure, i.e. either progressive disease or continued viable disease that exceeds 50% after multiple bouts of local regional therapy. And these patients, not uniformly, but should be considered in select cases for systemic therapy, given that you may have better outcomes at that with the use of systemic therapy. Likewise, we start to understand that there are some patients who have large intrahepatic disease that are taste unsuitable. So you can see this propensity score matched analysis that compared systemic therapy versus local regional therapy in patients who had large intrahepatic disease, defined as beyond up to 7. And those patients who were treated with upfront systemic therapy had better overall survival. And this is thought to be driven by better preservation of liver function. You can see that those patients who were treated with upfront chemoembolization had degradation of their albumin grade, leading to degradation of their Child-Pugh because of this collateral injury to the background liver, in contrast to systemic therapy upfront. We know from the Embrace 150 trial that atezobev can be efficacious among patients with BCLC-B disease, providing good median survival as well as responses in over 40% of patients. And so these two concepts in parallel now inform clinical trials that have been launched. So we see the ABC trial comparing atezobev versus chemoembolization for patients with large intrahepatic disease. And we've launched an ancillary study in the United States looking at atezobev versus radioembolization for patients with large intrahepatic disease. And so between these two trials, we think that we will have good data in terms of if these patients should be treated with upfront systemic therapy or upfront local regional therapy, and if one or the other, whom may do better with which. Now, the question may not be one or the other, right? This may not be A versus B, but maybe it's combinations. Maybe it's A plus B. And so these combination therapies are being revisited now because of this idea that the local regional therapy can release neoantigens and improve your immune response with the immune checkpoint inhibitor. And recently, we've seen data from Emerald 1. So Emerald 1 looked at TACE alone versus Durva plus TACE, and then the third arm was Durva Bev TACE. So single TACE, doublet, triplet. And in brief, what we saw is the doublet, Durva plus TACE, did not improve progression-free survival compared to TACE alone. Durva Bev TACE, the triplet, did improve progression-free survival compared to TACE alone. You can see median progression-free survival of 15 versus 8 months. Now, one of the questions coming out of this trial is this additive or is this synergistic? Meaning, do you actually just concentrate your benefit by using everything up front? And would you derive the same benefit from a progression-free survival or overall survival if you simply did this sequentially? TACE followed by systemic therapy if you progress. And we don't know the answer to that right now. These combinations are also being examined in the advanced stage setting, local regional therapy plus atezobev. We've already heard about the launch trial. I think the launch trial, questionable sort of relation to the patients we see in our clinical practice. It was all sort of Asian patients with hepatitis B. And so whether this applies to the patients we see in routine clinical practice, unknown at this time. But I think these trials that are ongoing will further augment our understanding of combination therapy in the advanced stage setting. These decisions are complex. These decisions should not be made by a single specialty, but instead should be really made in a multidisciplinary setting. So these are not only decisions about one therapy or the other upfront, but even as a patient progresses through their therapy, when they have progression or they have downstaging, and then also when you're thinking through these combination approaches, whether quick sequential or true combinations upfront. And I think that these multidisciplinary settings are actually associated with improved guideline concordant care as well as improved overall survival. So in summary, there have been notable advances in our systemic therapy options with the introduction of immune checkpoint inhibitors. Both atezobev and durvalumab are now preferred first-line systemic therapy options. In patients who fail these therapies, we do have efficacious second-line options. Once again, in our clinical practice, we consider lenvatinib or ipi/nivo for most patients who fail atezobev. Systemic therapies are now proven in the adjuvant setting. And then we've also seen some of these early data showing efficacy in combination settings for intermediate stage disease as well. And finally, we should continue to provide multidisciplinary care for our HCC patients to provide the optimal outcomes. Thank you. Happy to take any questions.
Thank you, Amit. We will take up the questions later on and taking us through this systemic therapy for an HCC. And now we have another talk, and this is going to be delivered by Dr. G.V. Rao, who is chief of our surgical gastroenterology. He is going to talk about HCC recurrence, post-surgical resection, and measure to prevent it. G.V. sir.
Thank you so much, Anand, actually. After listening to those couple of talks, actually, and all the people, surgeons like me think there's no role for surgery. Looking at those ROC curves, survival curves, and those tongue twister drugs that you have, I mean, it's very, very difficult for me to follow all these things. But I think most of the residents here seem to be convinced that there's no role for surgery. Now, this is basically because when I'm talking to the medical gas oncologists or the hepatologists, I'm talking about morbidity, mortality, and recurrence from my side as compared to biological behavior that you're talking about. It's completely different. I am not talking about the biological behavior at all. When you talk about my surgical result, you talk about morbidity, mortality, and recurrence. And there is no mention of recurrence in any of these talks with the medical oncologists or the hepatologists. Surprising. Now, if we are talking about curative intent, we are talking about resection, loco-regional treatments, or transplantation. Actually, my team here will vouch for it. And when we are talking about intermediate or advanced HCC, we talk about all these modalities, either in combined form or a sequential manner, so that these patients can be optimized and taken up for these interventions. And there is a lot of data to show that when you follow up these patients, they do absolutely very well. Now, surprisingly, you look at the predictors of recurrence. This is compiled by the medical oncologist. Now, if you look at this, the predictors of recurrence, I cannot choose a patient because every single patient I choose recurs. I cannot choose the patient characteristics because every single characteristic that is depicted seems to recur. And I cannot choose my resection because every single technique seems to recur. So at the end of the day, they feel that there is no role for surgery because everything that you're trying to do ultimately will end up with the recurrence of this tumor. Transplantation recurrence rates are lower, loco-regional therapy and liver resections are slightly higher, and non-transplantable recurrence is the major cause of precluding salvage transplantation, which showed comparable overall survival to primary liver transplant. Now, there are several concerns of this HCC. This thing, histological modifications induced by molecular therapies may explain different imaging findings of recurrent diseases, and differentiation between tumor-induced tumor necrosis and viable tumor with reduced arterial perfusion is really challenging, even with the best of the best radiologists that we have. And we have these advanced imaging tools, and maybe AI is coming in some way to help us to delineate which of these patients are actually true recurrence versus false recurrence. Now we have umpteen number of these things. Actually, maybe the medical oncologists and the hepatologists will not know about some of these things that we practice behind the scene. Actually, my transplant team will also agree with me that we have used cholangiograms, ultrasound, maybe some intraoperative VRCP, fluorescein dyes, and maybe we use some neuroimaging techniques to make sure that our recurrence rates are lower. It all started with this gentleman who started using this indocarbamine for HCC. He selectively injected this to identify segmental boundaries, increase the anatomical resection rates, showed better assessment of tumor margins, improved oncological outcomes, and overall survival of these patients. This was using indocarbamine for HCC, but surprisingly, this had a lot of limitations in cirrhotic patients. It required some amount of expertise with intraoperative ultrasound, which was not available at that time. And regenerative nodules post-chemotherapy limited the visualization of these things. And most of them could not reproduce the original data that was published. And we came in this movie, actually, we take some ideas from these movies. Predator came in, they showed infrared light to pick up some of this thing, and we picked up this concept to split or filter light, and we got this concept of using ICG into clinical practice, wherein we use split, filter the light, use ICG to pick up things which are not picked up on conventional white light. That is a simplistic way of telling how ICG is used in clinical practice. Now, this has got several advantages. Unlike the drugs that I mentioned here, it's an absolutely cheap drug that is available on the counter. Selective liver uptake, excreted into the bile ducts, enhances visualization, provides real-time liver mapping. It's got a very high tumor detectability, both on the liver surface and the surgical specimens, and it also aids in perfusion assessment. Very easy to constitute, administer, non-invasive, can be injected in any form, IV, lumen, lesion, node into the oculum. Natural orifices, high safety profile, cheap, readily available. No radiation is involved and no additional equipment is required. And it can be given liberally, and it can, once reconstituted, it is used within 6 to 10 hours. And all it requires is this equipment, that is a processor, where we have to change the mode from conventional white light to this infrared mode so that we'll be able to visualize these things. And we have shown that actually laparoscopic ultrasound, which is coming in a big way into clinical practice, actually my transplant team uses this very liberally actually to pick up this and make sure that the resections are good. And it has shown that ICG has got a very valuable role in the management of these resections. And we showed the combination of ICG and intraoperative ultrasound. It is shown to be better. And we start using both these techniques as in today, make sure that we get good R0 resections. So usually injected 1 day before. And you can see this, we are able to differentiate. Now you're all not talking about how to differentiate this. Now if it is homogeneously fluorescent, it means it is well differentiated. Partial, it means it is moderately differentiated. If it is completely peritumoral fluorescence, it means it is poorly differentiated or a metastatic. Here you can see this. This is partial fluorescence. Now this means on table, even before I make a send it to the pathologist, I can say that it's a moderately differentiated HCC. And looking at the margins of how it gets perfused, we should be able to get good surgical. Not only this, actually, look at this. Actually, even after you excise this, you send the specimen. This is just to show you the concept that I use for clinical practice. Actually, you send this entire specimen after you resect the thing, and you put this under the fluorescein. You know that it's a poorly differentiated lesion or a metastatic CA. So these are technologies that are used in current day clinical practice. And we use these techniques of positive and negative ICG staining, wherein you positively you stain directly into the portal injection, or negatively you clamp that and inject IV. Now, both these techniques are widely practiced depending on the expertise that you have in the institution, and both of them have shown to have significantly good results in getting overall good results in these patients. And now we started using the same thing actually on the robotic surgery. Though it is very early to say whether robotic surgery really improves the overall survival of these patients or that decreases the tumor recurrence, but there are initial case reports to show that definitely decreases the morbidity in experts' hand. And it's in the days to come, like all you have the data, in the days to come, it is likely that we can show that the robotic surgery could be and has less recurrence as compared to the other modalities that we have. And it is also shown that if you administer this, leaks is one of the commonest causes for recurrence. You should be able to check for leaks on table using this ICG technology, and it is likely that the recurrence rates or the morbidity is less in these patients. Predicting post-hepatic liver failure is the commonest thing, and again, ICG is very commonly used to predict this. I'll not go into the technical details, but it is shown to help in predicting hepatic liver failures in this patient, and it is also shown dynamically intraoperative dynamic liver function, and also it is shown to show the graft perfusion in liver transplantation. I think our transplant team has got significant experience with this. They start using this, and based on the thing, they know whether the graft is viable or not viable. So overall, ICG in clinical practice has become an essential tool for liver surgery. Hepatic tumor detection, accurate anatomical hepatectomy, increase the safety and accuracy of minimally invasive procedures, be it laparoscopic or robotic, extended dissections are possible, functional status and future liver remnants assessment is possible, and ICG seems to be a good indicator for graft perfusion after transplantation. And there are umpteen number of these extended extrapolations of this ICG in clinical practice, where photodermal therapy that you call, where ICG is tagged with the drugs, and these can be used, though experimental. I think looks like these things will come into clinical practice very soon. And it is shown that ICG has got huge role in current day clinical practice, and the evolving techniques and technology seem to increase the safety profile of liver surgery. There is yet another modality that has just come into clinical practice. It's called yellow enhancement. This comes from Olympus. Basically, you're looking at my building, AIG building, how it looks under white light and yellow enhancement. Basically, here, we used to filter the light, and the yellow component gets enhanced. And you can see this is just happens again. There is no contrast that is injected. It is just in the change of the mode, we change from white light to yellow enhancement. And just look at the pictures that we get on white light and yellow enhancement. And this contrast seems to give a better picture when you're trying to do dissections. Vessels, nodes, tubular structures, all are better identified when you're doing this procedure. Again, it is not related to vascularity. Here you can see that is a completely transected momentum gets enhanced better as compared to white light. And it is not just yellow, but these all the primary colors, red, green, blue, seem to be the positively or negatively enhanced. That gives us a sheer contrast when we're doing this resection. The fat content, distribution, the tissue stretch, and the thermal desiccation all seem to determine the colors that we see on the monitor. And this again, this is a concept that Olympus picked up from this movie called Avatar, where for the first time they showed this concept of yellow enhancement in the eyes of these people. And just look at this. This is what yellow enhancement means actually. Compared to white light, we are having a better demarcation between the surrounding structures. And I'll not skip this actually. When you're dissecting the porta, the lesser momentum, the nodes are better visualized, vessels are better visualized, and the dissections could be less vascular, and there could be less lymphatic leaks following these resections. But it is too early to say that these are improving the overall survival of these patients. But certainly the morbidity, mortality of procedures which are done can certainly be decreased by using these technologies like this, which also show, because it enhancing fat, fatty livers seem to enhance more when you're using this component, and it is likely that we more careful when you're using energy sources and dissecting the parenchyma, and also to check for any leaks on table. It is likely that when you're incorporating this technology, maybe we'll avoid liver biopsy in future. And actually, we have an ongoing project. Actually, this I'm releasing it even before it comes to the market. We have an ongoing project with Olympus right now. It's called Project Octopus. Here I'm talking about changing white light to yellow light on pressing the mode on the processor. But now we are incorporating AI into this, wherein the system automatically changes the colors, the background to the foreground. Your target dissection becomes the prime area, the surrounding areas become default. So this system is going to come into the market 6 to 8 months from now, and this is going to totally change the way in which you're going to dissect. It's called the Project Octopus. And this, I think, will make a significant impact in the way we are doing liver resections. AI, huge impact actually. If you see the number of publications, not only from your side, from diagnosis to genomics, but to predicting response, predicting recurrence, artificial intelligence seems to have a tremendous role. And in the days to come, whether you believe it or not, actually, I mean, I don't think anybody can remember all those flow diagrams and algorithms. Ultimately, we have to depend on AI to make sure that what we are following is right or wrong. We have the 3D reconstruction planning models which are available, which is likely not only to improve the teaching facilities, but also to improve the resection rates. This is coming more and more into clinical practice. We have virtual reality, actually, some of the publishing data that you've shown that these are coming into clinical practice. augmented reality is the other modality that is coming into practice. All these are likely to change the way in which liver surgeries can be done. And navigation surgery seems to be the ultimate. Actually, this we have been working for this with this group for the last almost 10 years right now. I think this will become a reality very soon in our own hospital also. We're integrating the preoperative and intraoperative images together using laparoscopic ultrasound. So we get real-time images on the screen. This is also tremendously improved the R0 resections. And there is data to show that it improves decision making, decreases operative time, complication rate, improves surgical precision, surgical safety, clinical applications, orientation and localization, and also teaching the students. This other thing that has come recently, we have acquired this digital pathology called the Vivoscope. Actually, it is already installed in our department here. We no more wait for the frozen section biopsy. This tissue basically is based on confocal microscopy. This gives pictures which are similar to histopathology HND stains. This takes just about 2 to 3 minutes to give this. This is what is available right now to shorten the time, to shorten the anesthetic time that we have for practice in clinical practice today. This is certainly going to make a big dent into clinical practice. And again, we all depended on these staplers, which are prehistoric, but now we have this intelligent staplers which have come into market. Again, to tell you that we have another ongoing project with one of the staplers manufacturers, wherein they're going to tell us the staple line histology. Meaning to say, it might not be helpful in liver resection, but when you're doing a cholangiocarcinoma, the bile duct resection, when you're transecting the bile duct, this will tell us whether the transection line is positive or negative on table. So we have umpteen number of applications of this AI that are coming to clinical practice, helping both the clinicians, the medical oncologists, hepatologists, and also the surgeons to improve the overall figures and also decrease the recurrence rates. So basically, it's a potentially curable disease. Recurrence rates still seem to be high depending on which data you quote. There are several factors that are involved. Anatomical versus non-anatomical resections versus RFA debate continues. Identification of predictive factors for both early and HCC recurrence could optimize the treatment strategies. Now, high-risk patients should be referred to treatments with lowest recurrence rates, like liver transplantation, and combination treatments could be more viable, more suitable for some patient. But research should validate combined therapeutic regimes. And I fully concur with the medical oncologists and the hepatologists are talking about all these future effects where the patient comes first. All these things could improve the overall survival. But I'm looking for some equipment like this, science fiction movie. But I just want the patient to be placed on a machine which diagnoses, cures, and the patient is out of the machine. I'm sure with all this AI coming to clinical practice, this could be the future of what is going to happen. Thank you so much once again for the patient here.
Thank you, JV sir, for taking us through this exciting journey and taking us to the concepts of neurotechnology, especially emphasizing the role of ICG in planning liver resection and incorporating a future technologies like AI, the role of AI in surgical resections. Thank you, sir. And now we'll take up some questions during discussion later on. And now we move to two important panel discussion. And what the panel discussion is going to be moderated by Dr. Arif. And the panelists for this first case are Dr. Naveen, Dr. Priya, Dr. Jignesh, Dr. Gautam Reddy, and Dr. Ravi Teja. May I ask the panelists to take the dais? And Arif, the stage is yours.
Good evening, everyone. First of all, I would like to thank Anand for this opportunity. Today, as a moderator, my job is to ask questions. I need not know the answers myself. Can someone help with the... So we have got the panelists, radiation oncologist, we have Dr. Jignesh, our interventional radiologist, Dr. Sujana, radiation oncologist, Dr. Ravi Teja, medical oncologist, Dr. Naveen, hepatologist, and Dr. Gautam, or gastroenterologist. Let's move on to the case. He's a 54-year-old gentleman who is known CLD with portal hypertension, probably NASH related. He did not have any viral etiology. He's a known diabetic and hypertensive. He presented with pain abdomen, loss of appetite, and loss of weight since 1 month. The preliminary CT showed a liver SOL, so MRI liver was ordered. He was found to have a large lesion around 11 centimeters involving multiple segments with a tumor thrombus in the main portal vein, which was extending into the proximally into the SMV. Along with we had done a PET scan which did not show any metastasis. There was no extrahepatic disease, and it confirmed the MRI findings. The AFP was around 1,000. PIVCA was 2,000, and bilirubin was 1.6, albumin of 4.7, PTINR was 12.5 normal range. There was no ascites, there was no hepatic encephalopathy. He was fitting into child PUA. So these were the images, the PET scan images, the tumors almost occupying the liver, the segment 4, 8, and 5, and the vertical extent, and also the coronal section, we can see the vertical extent. And these are the MRI images, huge tumor with the thrombus extending into the main portal vein till the SMV. So I would like to ask the panelists now. So before in the basic treatment principle in oncology is we decide the intent of treatment. So we decide the intent of treatment, whether palliative or curative. Dr. Jignesh, how would you proceed in this case? Whether with a palliative intent or with a curative intent, or you decide the intent later on, maybe after giving some local therapy or.
In portal vein, our intent our intention should be more of palliation rather than this thing, because the recurrence risk and all that will be higher. But in this scenario, what we thought of was, right, we'll attempt SPRT for the portal vein tumor thrombus.
Yeah, we'll go on to it. Yeah, we'll discuss it further. So presently we decide that it's mainly a palliative treatment, and we are going to control the tumor, and we are going to enhance the survival with whatever we do. So Dr. Sujana, how do you proceed with this case? Basically the intent. Yeah. Yeah, definitely.
Thank you. So as we discussed, it is a child PUC A score, no decompensation, NASH rated. And if you look at the BCLC stage wise, I mean, looking at the size of it, it's 11.5 centimeters, right? So it is beyond the transplant criteria if you look at that side of things. So we're looking at more or less intermediate stage with a high volume tumor, and it's a VP4, it's actually gone into extending into the SMB as well.
Right.
So yeah, I think I agree with it. It's in an intermediate stage where there's a palliative intent, but if he responds, then we can actually pursue further treatments where we can actually achieve for further downstaging or stage migration towards the left side.
These are the real world situations where frequently encounter that the intent can't be decided baseline. We need to give some therapy. Later on, we modify the intent based on the response.
Absolutely. So I think we've gone with the days where we're just going to fit in only one box. We're looking at stage migration these days. So if he responds to treatment, then we would actually move towards further definitive therapies as an intent to treat for these patients or curative intent.
Your point well taken.
I think the line between palliative and curative intent nowadays is blurred. So we cannot take one patient as palliative fit once into a palliative intent and then go into curative intent. So the terms are very vague nowadays because of availability of targeted therapy and immunotherapy. So in oncology nowadays, most of the times we go into with a hope with a curative intent. Then if it does not respond, then palliative intent. But upfront, we do not fit a patient right away into palliative intent.
So more of VP4 with such a huge tumor, we don't respond unless he responds exceptionally. The treatment would be like we start with palliative intent. So what would you consider the next treatment approach? The loco-regional therapy followed by systemic, or with starting with systemic, later on consulted with some loco-regional therapy, or only systemic, we follow the BCLC algorithm. It's a systemic therapy. It's a BCLC-C with portal lymphomas. Dr. Gautam?
Yeah, so we have discussed extensively in the previous sessions about the BCLC as well as the indications for systemic therapies. One thing I would like to add to that, just like Dr. Amit has already mentioned, the 2022 Barcelona classification of BCLC is already kind of outdated in the present context. So INACEL has actually come up with the 43 recommendations last year, where they have actually classified BCLC-C into C1 and C2, where there is extrahepatic spread versus where there is only tumoral thrombosis without a extrahepatic spread. So in those patients without an extrahepatic spread, always I would, as per the 43 recommendation, as per our center management, we would go for a loco-regional therapy first, followed by a systemic therapy. That would be my recommendation.
That's how we go. Then your 2 points. How do you consider whether start with systemic or later on? We have got some fantastic systemic therapies available now within macrovascular invasion. We have seen the data also. Whether start with systemic and later on consolidate if it doesn't find a good response. How do you go about it?
I think as Gautam says, if it's a C1 platform that we're looking at, then local regional therapies. I think this is a good case for SBRT, along with the TARE as a local regional therapies, and see the response to it, and then further go ahead with the systemic therapy if needed. But I think SBRT plus TARE is what I would actually think about for this case.
Okay. So we moved on. So BCLCC, yeah, sir. Yeah.
I
So
think
your expert opinions.
Yeah, I think if this patient was seen in our center, what we would do is we would start with systemic therapy. So the reason that we would start with systemic therapy is because a fair fraction of these patients will actually have micrometastatic disease and present with metastatic disease on their first imaging post. And even though you may induce good local tumor control with SBRT or radioembolization, if they have micrometastatic disease, you somewhat miss the boat by treating them locally and not systemically. So I think it's different if they had VP2, definitely if they have VP1, then I think local regional therapy up front is reasonable. But once you have VP3, VP4, the chance of having metastatic disease short after is quite high. And so in our center, what we would do is we'd start with systemic therapy. We would then continue systemic therapy for the, sort of 2 months, let's say, and then repeat imaging. If the patient doesn't have metastatic disease at that time, so you then have confirmed that this truly is localized disease, then I think it's always reasonable to add in the local therapy. The disease control rate for these new systemic therapy options are extremely high. And I think those patients that would present with metastatic disease had metastatic disease. And so that's why I think that you avoid, quote unquote, unnecessary local regional therapy, where you would then, potentially have liver dysfunction that can come from particularly treating a large intrahepatic disease like this. So that's our typical approach, is to start systemically and then consider adding in the local regional if they continue to have just local regional disease.
I kind of agree with what Dr. Amit says, because as a radiation oncologist, my concern would be the size of the tumor and also the liver reserve. So here, if you look at this tumor, it's around 11.5 centimeters. So typically it would be a little difficult for us to spare the normal liver.
Yeah.
So with such a big tumor, maybe we can start with systemic therapy and reassess maybe after 2 to 3 months. So my job would become much easier to encompass a smaller volume at a later date. So that would be my concern. But even though if you look at the RTOG 1112, which was published recently and which is which is added sorafenib along with SBRT, especially in macrovascular invasion, the maximum allowable tumor extent is around 20 centimeters. But the median tumor size is around somewhere between 8 to 9 centimeters. So yeah, but even then, looking at the size
So
of the
you're
tumor, I
talking
wouldn't
about
go with. Correct.
SBRT with TKI versus
Yes. I mean,
versus
in,
TKI
yes,
alone.
correct. Because that trial kind of fits into this criteria. But there, I mean, I would still be hesitant to offer SBRT upfront because you have to treat both the portal vein as well as the primary tumor here. So downsize the tumor first and then probably take it up for local treatment.
Yeah, I agree. I think the other thing that is interesting about these trials is we always talk about maximum tumor size, but it really isn't necessarily even just tumor size, it's tumor location. How many segments are you involving? You can have a very large tumor that's involving 1 or 2 segments, and from a radon perspective, you're like fairly easy. I can spare all the rest of the liver. Versus a centrally located, you're involving 3, 4 segments, then it becomes much more difficult on you. And if you start with systemic therapy, you have some degree of response, then it becomes much easier
and more
to
than that,
spare.
we need to look at the normal liver reserve also, which is
Yeah.
typically we call it 700 cc. So that
Yeah.
is what we look at.
But it's really, I think we have to change the way we actually report these in clinical trials, right? So it should be the amount of liver spared or the number of segments involved, not maximum tumor size.
Yeah.
Because I think at the end of the day, you can have a very large tumor that's on the edge versus in the center, and the maximum tumor size is the same, but very different from a local regional
usually
therapy
the
perspective.
premise is you have a CLD patient. Usually the liver is most of the time is shrunken.
Yeah.
So that is the reason traditionally we follow that 700 cc or volume of normal liver.
I may interrupt regarding only having Isobeva in this scenario and waiting for 2 months of dosages and 1 month of waiting for imaging. Are we not missing on giving actual downstaging to him if by not adding any downstaging modality, local regional therapy?
But if you have metastatic disease, it doesn't matter if you only treated half the disease at that point. Then if you have metastatic disease in the lung,
Systemic plus local regional therapy upfront.
but if you have metastatic disease, then it doesn't matter if you induce response in the liver. Right? The idea here is more so a test of time. Do you have metastatic disease or not? There's no rush to induce the response up front. Once again, if you achieve disease control for 2 months, and if you're going to have 30% of people who have a response, it's going to make sort of the radon's life easier. And so it's the type of thing where at the end of the day, I think we're often in a rush.
Yeah.
So yes, in locally advanced disease, we, as previously Dr. Vamshi Krishna has said, we do detect CTCs in the liquid biopsies. So definitely there is macrometastasis, especially in the locally advanced tumors. So better to go ahead with systemic therapy, which will address macrometastasis also in this case.
So you do CTCs before?
No, I am just,
yeah,
because
okay.
in the liquid biopsy, there is a
Yeah.
chance that we can detect with the
definitely
sensitive
the
techniques.
micromets
Yes.
are concerned with such an advanced disease. We tend to start with systemic, control the micromets. Later on, the patient responding to consolidate, we can give some form of local therapy. With the best of the systemic therapies available, what we are going to achieve. So that is a BEV in this condition with macrovascular invasion. We can see the subgroup analysis here. I think the slide is not visible. Yeah, sir. Unfortunately, we don't have answer for that, sir, now.
At present, we do not have answers, sir, with the available sensitive techniques. So as the time goes on, we may have a liquid biopsy that are ultra sensitive, which can detect even the CTCs in the blood.
I think what I didn't understand is, Dr. Amis, is that with the premise that there may be
I think one.
Yes.
One particular problem is very high.
there is or there is no.
One probable predictor is high FP and PIVCA, which suggests
Correction, a CTC will be seen even with a primary. It's
Yes.
not that if
Yes.
you have CTCs, they are
Yes.
micromets. The
Yes.
idea is high CTC volume indicates more tumor burden. And more important is what is the response of the CTC? That is useful. So I don't think you should go with the idea that you do a CTC and that indicates micromets. That's not
Yes,
what
yes.
it is.
True, sir, true.
I think it's actually a very important point because we don't want to get into the idea that CTCs means metastatic disease. Because otherwise, we then say this patient's not resectable, this patient's not transplantable. You will see CTCs in actually almost many tumors, and so tumors are always shedding CTCs. It's just that they often get treated with your intrinsic immune system. So I agree with you. It's just if you have high CTCs, but I don't think CTCs are ready for prime time. In terms of the question, what's the actual answer in terms of how do you know if this patient is metastatic? Test the time, right? Time will tell. Now, the only reason I say this, and I get your point, we did staging, patient had a PET CT, the patient had a CT chest, the patient doesn't have metastatic disease. The only thing that I say is that with VP4 disease, it's the type of thing where many of these patients do have micrometastatic disease. You missed it because they were small. But we know that 15% of patients will then present with metastatic disease on their first follow-up scan. And I'm not saying that you only treat with systemic therapy. It's just the idea that to treat it locally, particularly with large intrahepatic involvement, you are taking that risk of then inducing liver dysfunction, where you then shot yourself in the foot in terms of further systemic therapies down the road.
So this slide shows that with best of the systemic therapies available, that is Obeva, we see a median overall survival in the macrovascular invasion subgroup of around 14 months. That is what we achieve with giving systemic therapies. So the combination approach is the better way to approach these patients. It's still exploratory in the advanced disease, but we need to, in real world cases, we start with some local regional therapies, then move on to systemic therapies. Though I agree with Dr. Amit that we would have started other way around because it's a locally advanced disease with VP4 to start with systemic therapies. So we started with two sessions of tear. This is the tear images. The Y90 is being taken up in the tumor but not in the thrombus. So after giving 2 sessions of tear, the patient moved on to receive SBRT in this patient to the PV thrombus. So since the Y90 was not taken up in the tumor, the SBRT was given to the tumor thrombus, and later on he moved on to receive 5 sessions of atezolizumab. So during the after the doing the loco-regional therapy, he was assessed during the planning period. He was responding, and during the sessions of atezolizumab, the AFP was stable. He was symptomatically improving. So the imaging was done after 5 sessions of atezolizumab. The tumor volume had shrunken, but to our surprise, the AFP had gone up now. So it was to begin with 1080, it had moved up to 6152. Though the tumor volume had decreased, now the bilirubin has shooten up. It had become 11 with the raised liver enzymes, alphas of 572, and deranged coag profile. So we have got 3 things in our mind with this case, that either it may be a liver decompensation or an immune-mediated liver damage or a progression of disease. So there is surely a biochemical progression, increase of AFP, but a tumor volume has reduced in MRI. So I want to ask the panel, maybe Gautam and Dr. Naveen can take it up, and Dr. Ravi Teja, that how we differentiate this, what has happened with the patient. Is it liver decompensation or progression of disease, or it's just an immune-mediated liver damage? Do you have anything?
Did we have a PET?
Also, we had MRI. It showed the reduction in tumor volume. They basically wanted to rule out if there's an obstruction, where there's obstructive jaundice or something like that. Also, it showed a reduced tumor volume, and the patient was not fit to do multiple investigations. So he suddenly deteriorated after 5 sessions.
So as Dr. Amit has pointed out, the point that it was a VP4 to start off, even
Yeah.
though the primary tumor has shrunken because of the locoregional therapy, most likely this patient might have had a metastatic disease elsewhere, which would probably explain the
Yeah.
high alpha fetoprotein in this patient. So
So you think it's
before high
the
AFP
systematic
levels,
progression, systemic
most likely
progression.
a systemic progression would be what I would think. And along with that, probably combination of checkpoint mediated liver injury and an underlying decompensation would have contributed to the
So
worsening.
multiple factors. Okay.
Multiple.
Dr. Naveen?
I think most often these patients who don't die of HCC, they die of decompensation, what I believe. I think there's probably progression of progression of the decompensation. And of course, disease is also progressed from HCC point of view because AFP has been elevated. So as we've been discussing, it probably would have been a micrometastasis which progressed. I think what has actually made him worse or is the decompensation that is happening, which is the primary driving factor is what I think.
The same, I think progression could be one of the reasons.
Uh-huh.
And if you see the hepatitis due to immunotherapy cannot be ruled out, and as well as decompensation. I feel both of them should be, I think he needs a PET CT to rule out any systemic metastasis and further workup.
Sir, your expert opinions.
Yeah, I mean, I may be proving wrong, but I think this is all induced from the therapy. I think this is radiation-induced liver failure. I think this is from the low. I mean, once again, I may be wrong, but if I saw this patient, I'd say this is liver injury from the local regional therapy. He probably has. I mean, we'll see if he has metastatic disease, but with the AFP going up, I just typically, if we see immune-related AE from the atezo, it would be more AST and ALT. This is primarily bilirubin. The AST and ALT less so elevated.
Yeah.
It looks like liver dysfunction related to me. And with 2 tears followed by SBRT, I think this is highly likely related to the therapy.
Actually, in this, it was 2-tier system, single tier. He was actually mentioning about the mass scan first and the tier Y90. And regarding Y90 delivery, we didn't intentionally target the VP4, the main portal and right portal, because the supply will be from common hepatic artery. So our target was only the tumor and the subsegmental portal vein tumor thrombus. And that's why we opted for SBRT, because we wanted to target the lower aspect of the portal vein. And 3 months after the tear session, where we usually get the MRI done, patient had no ascites, and I think the LFTs were okay after 3 months after tear.
But the radiation-induced liver injury can take time. It doesn't have, it doesn't have to happen within the first couple of months. So sometimes you'll see because you still have radiation effects that can last 6 months later. I think it's hard to say that it's not necessarily related. Once again, I'm not saying for sure that it is. Just if I saw those labs, this looks like liver dysfunction more than immune-related AE.
Yeah, I agree with Dr. Amit, but the thing is, I think we need to have multiple differentials here rather than just pointing out to one
There's
thing.
no
Like,
way to differentiate.
correct. There is
Depends
no
on
way.
clinical
There is no way
judgment,
to
yeah.
differentiate what has caused the liver damage or what has caused the insult to the liver. So I mean, if possibly RILD could be one possible differentials here, but I think we should look at other possible differentials also at the same time. The disease could be one particular reason, one major reason, or the immune-induced toxicities, hepatitis, or even radiation also. But as far my knowledge goes, we haven't really radiated the whole portal vein, and we were very constrained with respect to the doses what we have given, because just a month before he has received yttrium 90 tear he has received, and we had to kind of accumulate the whole radiation effect, and then had to take a call on how much dose we have to give. But with the doses what we have offered for this particular patient, I don't think radiation is a cause, but I'm just assuming. I mean, I'm just defending my own this thing. Yeah. I know. We have just
Yeah, that's a possibility. Yeah.
One golden rule, what he said here was, if the enzymes are elevated, more than bilirubin, it's probably drug induced. If the bilirubin is high, it's probably liver dysfunction. Either it is radiation induced or the patient is decompensated. But what we feel in practice, if the enzymes are elevated, we get a ANA done. Also IgG, which is positive in 30 to 40%, which will help us identify the immune checkpoint inhibitor related.
IgG level and
so that's commonly what we follow. If the bilirubin is very high, we don't usually think that it is ICI induced.
Bilirubin in this case is 11, so it is significantly 11.
11.
Can you just comment on the quality of life of these patients for an overall survival of about few months, 4 to 5 months? Overall survival you're improving. No, very frankly, overall survival you're talking about, quality of life of these patients for an estimated overall survival of about
14
5
months, sir. According trial data, it's around 14 months.
That is for I am brave. That's overall survival in the whole. So the problem with these clinical trial is the biological behavior of the tumor is never addressed in these patients. You are including all the patients stage A, B, C, the more of the A stage A disease, and B some and few C in your study also, Anand. So the problem here, we had just a discussion in the previous case which Shantan presented. The bilirubin, he has a large disease. There's a tumor was there, and the patient responded very well to lanvatinib, and that too on irregular therapy, not on a regular lanvatinib therapy. And this patient is doing well for 2.5 years, and the tumor had disappeared. Right, and this was a very well documented tumor. Here we have a gentleman who has a tumor burden, and this in spite of extensive all modalities of therapy, and still is deteriorating. So what Dr. GV Rao is trying to say is, at the end of the day, what we are going to try to achieve, what should be the end point in this?
So I agree that most oncological trials, or from a HCC perspective, everybody feels that yeah, 2 महीने में क्या फर्क पड़ेगा. But for a family which is affected, really matters.
I think with respect to Dr. Shantan's case.
But this is why when you take a look, so even if you take out the VP4, this patient had what, 11 centimeter tumor up front.
Yes.
Let's say that you even had local therapy. This patient had an 11 centimeter tumor that was involving at least 3 segments. This is the whole idea of these ABC trial and the LOS-B trial, right? I mean, like, this is a patient, you take a look at the CUDO data, this is a patient who has large intrahepatic disease.
Yeah.
And this is exactly what his analysis showed. If you treat local regionally, you have degradation of liver function. And so what you've done is you try to be aggressive. But being aggressive can also cause exactly this. It can cause liver dysfunction, and you can actually hasten death. So I agree with the idea of we want to do everything. We want to try to treat the tumor. But the easiest way to kill the tumor is to kill the patient. Right?
Yes.
And that's exactly the issue with being overly aggressive. You get high AEs and you cause liver damage. And so that's why we have to be smart about saying it shouldn't always be combination therapy. Just because you can do it, it's at high risk of causing liver injury.
So
and
many
actually causing
ongoing trials are addressing this question. Maybe with
I think we
portal
should
vein
also know
thrombus,
where
they
to
are
draw the
combining the
line with respect to
therapies.
the size and
We will get the answer maybe in the future trials. So right now, single modality treatment, systemic therapy would be the answer for this.
We here have a VP4 lesion, and tear, you have actually not targeted VP4. So this is just a natural progression of the disease. VP4 disease, if you just treat the local tumor there without just ignoring the thrombus down to SM, the disease is going to progress. Clinical deterioration.
Just an abundant question that I just wanted to ask. So if this patient, as Bala has actually mentioned, if you don't do anything, what was going to be his survival rates? If you do chemotherapy upfront initially, see the response, what would be your assumed survival rates for this patient? And if you actually go to local regional therapy and followed by systemic therapy, what would have been your assumed survival rate?
So nobody, we would need alternate realities to know how he's going to do on all these different therapies. I agree. VP4 is a bad prognostic sign. So when you take a look at the IMbrave 150 subgroup analysis, VP4 on atezo-bev, I think the median survival around 7 months or 6-7 months. It's a bad disease. The only thing that I was saying is not, and I think that we have to be sort of quote unquote better than atezo-bev alone. But I think what I would say is that what you would do here is by doing atezo-bev upfront, is you would then select, is this patient going to have a bad tumor biology where you're going to have metastatic disease, and then you're going to preserve quality of life. You're not going to induce liver dysfunction by treating something that doesn't matter because the patient has metastatic disease. So you wait 2 months, you see the patient has metastatic disease. And if so, then you're like, okay, fine. I understand I'm not going to sort of give you a good long-term survival, but we're going to give you good survival benefit and we're going to give you good quality of life. If that patient has a response and that patient or otherwise has stable disease, then you can say, okay, fine, you have a quote unquote good tumor biology for VP4 disease, and we can now consider sort of adding in selective local regional therapy, whether that's TARE, whether that's SBRT, but it's also the type of thing where I would do it in a staged fashion. It seems like, and once again, I wasn't involved here, patient received 2 TAREs and SBRT and then started on atezobev. And I don't know if the patient had imaging between, but I mean, I would do this more slowly. So you then sort of once again
So
understand.
before every modality, there was imaging done. So as a planning paired before the SBRT, it
Okay.
showed the shrinkage of tumor. That's why
Okay.
they proceeded with it.
So you did
And
it sort
also
of
the AFP was stable.
Yeah.
Suddenly deteriorated after 5 sessions. That's how.
Yeah.
So I thank you all for the wonderful discussion here. I would like to conclude this panel. Thank you all.
The panelists as well. Dr. Balachandran, who is Chief of Transplant Surgery. Dr. Jagadish is not there today. Dr. Jignesh will be joining us. He's an interventionist. Dr. Soumya, Dr. Nitin Jagtap, the gastroenterologist, and Dr. Avinash, medical oncologist from our hospital.
Good evening, everyone. We now move on to our second case for the evening. After the exhaustive and in-depth discussion, this case will be a quick revision of all the guidelines and talks we've heard so far. And I'm sure everyone must be hungry, so we'll keep this discussion very quick. I present a case of 57-year-old female who's a tobacco chewer and a known hypertensive who's on treatment, evaluated for vague right upper quadrant pain with loss of appetite and found to have an SOL in the liver. Came to AIG, she has a BMI of 31 with a performance status 0. Her cross-sectional imaging PET showed a multifocal HCC with a largest lesion of 10 centimeters into 13 and LR5 lesion with no extrahepatic metastasis, AFP of 16, cirrhotic liver with no ascites, child score A, 6, and with an albumin of 3.1, and upper GI endoscopy showing small low-risk varices. Would you consider biopsy in this patient? And if so, what are the indications of biopsy in a patient with HCC?
A known CLD, when it's diagnosed and referred to us as a CLD, and in MRI or triphasic CT, whatever is done, and the features are predicted are towards LR5, we usually do not go for biopsy. In scenarios where, according to LIRADS, not confirmative of HCC, there is a doubt, or in a case which is not a CLD, in that scenario we go for biopsy.
To sum it up, we go for a biopsy in a patient with non-cirrhotic HCC, and also in cases where the lesion is not clear and where cholangio-CA is a suspicion.
Patient had metastatic disease and is being considered for systemic therapy, I think it's also reasonable to do a biopsy at that point, because then that patient already has metastatic disease. So even if you get a sort of tumor seeding, et cetera, you haven't changed that stage. And there now are several studies that show you actually change diagnosis in about 5 to 10% of patients. You find mixed tumors or you find pure cholangio. And I think the one thing is, if you're going to go down that systemic therapy route, it's not so much about, the NGS, all these kind of other factors that you can get off of this. It's more so just a matter of confirming the HCC diagnosis and making sure you don't have a component of cholangio. Because if it's cholangio or mixed, you've gone down the wrong treatment sort of algorithm and you've missed the GEMSIS.
Maybe in
So-
this setting, it would be
This is liver localized, so I wouldn't, but I'm just saying, like, that's the one other thing just to consider. If the patient has metastatic disease or is being treated with systemic therapy, it's reasonable to do a biopsy in those cases.
probably in this setting, CA 19.9 could be valuable in guiding us for suspicion of a mixed tumor. Not necessarily. Moving on to the next question. How do we manage a patient with high-risk esophageal varices in patient with HCC in a setting of primary and secondary prophylaxis? And would the approach change in the presence of PVT?
For a primary prophylaxis, those who are of risk of care. Right. Patients who are having total vein thrombosis considered as high or
Thank you. I think the message is pretty clear from all the talks and from Dr. Nitin's opinion. Screen the patients with HCC for viruses. If high risk, either go for EVL or start beta blockers. And if the patient is a bleeder, definitely treat the bleeding, go for an endoscopic management, wait for a period of 2 weeks, and consider immunotherapy. How will you approach this patient? What are the options to be considered? Would it be locoregional therapy, or do we go for systemic therapy straight, or role of combination therapy and role of direct LT?
More. I can come. I thought it's 11 centimeter. Here you have given me a used tumor. What else can you apart from transplant? I'll use the.
But he's beyond Milan criteria with 13 centimeter tumor.
If there is a criteria called Toronto's criteria.
Yes.
Takes any tumor, any extent, doesn't even talk of AFP. Even there you get a survival rate which is 5%. Here I agree it is going to be beyond UC. There also you are going to get a cure rate of about 65%, 65 to 70%. So is there any downstaging or is there any other modality which
there are multi-centric address?
I think we don't have any data where we're considering upfront LT beyond Milan with taking Toronto in consideration and comparing it with the downstaging and followed by LT if the patient is a responder.
Yes, I agree that there is no data which shows that downstaging is going to give a better result in this.
Volume. Largest volume, but
well, Dr. Singhal, would you like to opine on this?
So how many segments was it involving?
Sorry?
Do you know how many segments it was
It's
involving?
multifocal HCC, more than 3 segments.
Yeah, multifocal. Then I would probably start systemic in this.
And with systemic therapy, in this patient, however, we chose, because the maximum tumor size was 13 centimeters, and we chose to go ahead with TARE. And to discuss regarding the locoregional therapies, let's have a discussion on the choice of locoregional therapy in this patient, TARE versus SBRT, and which one would we prefer in the presence of PVT?
So when it was again, the word multifocal is a little misleading. Suppose if all the multifocal lesions are very close by in the same segments or adjoining segments in the same lobe, then and the size is more than 10 centimeters is beyond SBRT, and the TARE actually would be a good option here because the dosimetry has changed. The new dosisphere trial has shown that the way we are actually utilizing TARE, the way infusing the particles has changed drastically right from where it started with the SARA trial. So in this scenario, I think TARE would be a good option, but downstaging or even palliation.
Yeah, no, I think it depends on the imaging, right? I mean, like right now we just say multifocal, but all of us are sort of, we don't know.
Unilobar.
Yeah, I mean, it really depends on how many segments are involved. I agree that if it's all on the sort of same side, and you can actually spare a lot of the liver, then radioembolization.
If it was bilobar with multifocal lesions, even we wouldn't have taken that case.
Yeah, no, agreed.
No one's actually discussed regarding combination therapy, combination of locoregional therapy followed by systemic, the whole concept of neoantigens and increased sensitization to immunotherapy. Dr. Soumya.
Combination. Some here therapy. Yes, with lenvatinib. All these studies are going chair with chair followed.
Dr. Avinash, any opinion? What's your experience with combination therapies with systemic after locoregional?
To a certain extent, that some locoregional therapy, combining or following it up sequentially is something which we should allow the disease biology to manifest itself. Because ultimately, in this particular patient, if I agree with Dr. Bala that we are actually looking at transplant because there is no BP4 lesion, and then we can offer some curative treatment. Going down that line, I feel that I don't have an answer whether it's combined or sequential, but definitely locoregional followed by systemic or systemic followed by locoregional would be a way. We don't have an answer as of yet.
In this patient, yeah.
Of a case which is multifocal, both lobes, I would say systemic first. That's what is going to attack everything. You're going to target one lesion with tear. What are you doing with that? Unless it's in one lobe, like you said.
The one trial we have is Emerald 1, right? That's the one trial that's reported. So when you combined durvalumab plus TACE versus TACE alone, the responses were higher, although the responses were not durable. So progression-free survival was not different between the two arms. You needed to do durva-bev plus TACE to improve progression-free survival. So I agree with you. The whole concept is theoretical. And we do a lot of hand waving because we like to sort of talk about these neoantigens and the improved responses. But we do see higher responses with using the two encounter. But once again, it goes with the idea, same thing I said, I don't know if it's additive or synergistic. So like we just don't know. Well, that's one thing that we keep, yeah. So
The house seems to be divided on this. We did test the theoretical concept in our patient. We went ahead with TARE and followed by systemic therapy. So coming to the systemic therapy, choice of systemic therapy in this patient, although we've discussed extensively, how do we decide between TKI versus immunotherapy, and is there any role of combination therapy? And what about the etiology influence on systemic therapy in this patient? Dr. Soumya.
Coming to combination therapies, atezolizumab, that is again a combination therapy of immune checkpoint inhibitor plus anti-VEGF. And some more trials are underway, like TKI and immunotherapy combination in is cosmic and lead. But none of these have any proven now, and just stick to systemic therapy alone, therapy with immunotherapy.
So when do we start systemic therapy? Let's say we've gone ahead with TARE in this patient. When is the ideal time to start systemic therapy? Dr. Avinash.
So I think if we were to consider systemic therapy as lenvatinib or something like that, going by the trial, they started it 3 days after TARE, right? Yeah. But regarding to the systemic therapy in terms of, it's always immunotherapy, and if I don't have a valid reason, I mean, if I have a valid reason to avoid immunotherapy only, then we'll think about the subsequent systemic therapies. So here the choice would have been, TARE or CERT or TACE, whatever, and then followed it by a systemic therapy would be atezolizumab.
Coming to the next part of the question here, whether the etiology is taken into consideration while choosing the systemic therapy, I'd still consider immunotherapy. IMbrave 150, although it showed better benefits with viral etiologies, I think that representative the population in the study group were also mostly viral etiologies, and even Himalayan trial has shown better efficacy with NASH-related HCC. So irrespective of the etiology, I would still consider immunotherapy here, considering its
As of now, we have
efficacy.
adequate data to support that there's no role of etiology while choosing systemic therapy in patients with HCC. Moving on. I'm just skipping the theoretical aspect in interest of the time. We went ahead with TARE, followed by immunotherapy in this patient. He received 3 cycles of immunotherapy, and there was elevation of transaminases after the 3rd dose, which was found to be 320 and 290. So at this point, would you consider a diagnosis of immune-mediated hepatitis in this patient? And what would be the management protocol and role of re-challenge with immunotherapy after the onset of immune-mediated hepatitis? Let's have a discussion on this. How would we diagnose immune-mediated hepatitis, or would we consider?
So it's just a diagnosis of exclusion. I mean, you have a clinical setting in which we have a chance of likelihood is quite high, and we rule out other etiologies like viral markers, and this is a female patient. So as rightly pointed, we also should do we should have had a baseline ANI if required. And then yes, it definitely points out to be immune-mediated hepatitis because the bili is normal, OTPTs are elevated. So it's a fast a diagnosis of exclusion that should be done very fast because treatment implications are phenomenal, isn't it?
And how would you treat the patient with immune-mediated hepatitis?
First, as Dr. Avinash said, like to exclude alternative possibilities for liver injury like reactivation of viral hepatitis. Hepatitis B seems to be more notorious. C reactivation is seen less likely. Other drug-related drugs causing hepatocellular damage, I would like to exclude. And once it's proven or all the etiologies have been excluded, usually in case of immunotherapy-related hepatitis, biopsy may not be necessary. So it's a clinical decision, and if it is a grade 1 hepatitis, grade 1 adverse reaction where there is less than 3 times elevation of liver enzymes, I would like to continue immunotherapy. If there is grade 2 reaction where there is 3 to 5 times elevation of liver enzymes, I would like to stop the therapy, monitor every 3 days. If the liver enzymes are worsening, would go with steroid treatment. And upfront steroid treatment when it is grade 3 or 4 hepatitis where there is liver enzyme elevation of more than 5 times. In grade 4, we have more than 20 times elevation of liver enzymes, and immunotherapy steroids at a dose of 1 to 2 milligram per kg body weight will
as rightly pointed out, exclude other etiologies, hepatitis B, C, and reactivations, and consider the testing for autoimmune markers. And in this patient, she had ANA of 4+ with IgG of 31. We started her on steroids with rapid taper from 30 mg over a period of 3 weeks, and complete resolution was noticed. And after imaging after 3 doses, there was complete response. There were no active lesions with an AFP of 9. And at this point, should we consider this patient for transplant?
It's still not clear to me whether she had PVTT from the very beginning.
There is no PVT.
Give me the clinical details properly.
There is no PVT.
Transplantable. It's transplantable.
Regarding the Toronto.
So that's what I'm saying. For a surgeon, patient was transplantable now.
The patient landed up with hepatology, so
that's very unfortunate.
No, it happens most of the times. It happens in the MDT that the ball moves towards the interventional radiologist or the ball moves towards this. So when we are sitting and discussing it, so the majority always matters. Yes. I agree with you.
It is over, yeah.
No, actually, you're given 3 cycles of chemo.
Yes.
Immunotherapy. So the problem is most of our patients can't afford. So if we come down to the basics, 3 cycles, then they don't turn up for transplant. It's a different story.
The patient, however, was not very keen on transplant at this point. We continued with immunotherapy for another 3 cycles, and after a gap of 11 weeks from the last dose, we transplanted the patient. This is the explant specimen, and the patient is doing well 6 months post-transplant with no rejection and on active immunosuppression with stable graft function. Thank you.
We have had 8 patients treated, 7 transplants and 1 resection. The resection patient had 100% response. And most of the other patients had about 50 to 60% response.
Paper.
No, a couple of them had complete response.
The paper will come out in a week or two. Give me
That's
some time.
fine, sir. But I'm just curious because what I want to say is that the PET scan may show complete response, but on pathology, it is not showing a complete response. Correct. 2 had partial and others did not. That's what I'm trying to say.
In fact, the literature is actually against it. Although the imaging might pick up complete response, incomplete response, the pathology usually shows complete necrosis. It's the other way around, yeah. Yes.
And then when you take a look at the path specimen, there's
Complete
people who have a
necrosis.
complete response. So it goes both ways, but I agree that at least the neoadjuvant data, the early data, suggests that our imaging response to immunotherapy isn't good. We are actually underappreciating the degree. This patient, so it depends on sort of the initial tumor burden and the way that we do it. So if they have reasonable tumor burden, always were liver localized, we prefer a washout period of 3 months. If they're downstage from having vascular invasion, then we typically want a washout period of at least 6 months, if not a year. You can do it. I mean, but more so, you can give lenvatinib or something. But really, our sort of goal for this washout period, especially the ones who have vascular invasion at baseline, is I want to see what their tumor biology is naturally, because we're going to immunosuppress them, right? So the first 3 months, they probably still have some degree of immune activation, and then after that, you start to actually come to an immune neutral environment. And so I want to see if they're going to actually continue to have complete response or if they're going to recur. And those patients who recur are probably going to have a bad post-transplant. So I'd rather know about this rather than transplanting them and having recurrence after. So that's why we prefer a longer wait time if you come down from vascular invasion downstaging. Dio.
So in a patient with like this where the AFP was only 16, if I'm right,
Yeah.
and say any size without extrahepatic metastasis, many people, many centers in the world have actually are practicing it we're not talking about the centers who are doing cadaver transplants, but the living donor transplants. Many publications are there where some of them have been downstage, some of them have not been downstage, but they still have given a survival rate of recurrence-free survival rate of 78% at the end of 3 years, and similar at the end of 5 years. So only saying that, okay, the transplant benefit is actually forgotten here. Though this patient, I don't remember if she really had a peripheral tumor thrombosis, or did she? No, she didn't have it. So she came to us with I think 2 cycles or 3 cycles of immunotherapy. Now we saw the result. But what I'm trying to say is that, say, if you look at that BCLC staging that has come up with to 2022, you are saying that immunotherapy is actually complete response is only 10%, or maybe 10 to 30% if you extrapolate it. You're right. But if you see many centers, especially the data from the Eastern centers have said that TACE plus STAIR or TACE plus SBRT plus tumor, say transplant for tumor thrombosis patients with VP2, VP3 diseases has given a survival benefit, say up to 57 to 60% and 5-year survival rate. So why are we actually sort of trying to say it's just for the discussion's sake? I know the majority is all medical here. 57%, 57% 5-year survival rate has been established and published also. And if you go to the West, like the Eastern data, where if you see the Korean data and everything, they've even gone up to see, I think Dr. Bala also will say that 68% survival. So, like say, I think, I mean, just not to say that, okay, transplant benefit should not be considered, but I think in a scenario like this, I think transplant benefit should always be taken into consideration.
So we are aggressive with transplant, and I started my talk saying that anyone who can be transplanted should be transplanted. But I mean, it gives the best long-term survival. So I don't want my comments to be misinterpreted that I don't think that transplant should be considered. I think what you need to do when you see this patient in front of you is to say, what is our long-term goal? Right? And so, like, I mean, it's hard doing this in this kind of setting versus seeing this patient and having multidisciplinary discussions. But clearly there was the discussion of this patient is a good transplant candidate. And so then there would be the goal of that. And I think this patient is very different than the VP4 patient when we first started. And I think the key thing is what you really are doing, I think your discussion, your sort of lecture talked about this well, is actually, at the end of the day, what we do somewhat matters, but it's all tumor biology. And we take credit for the good tumor biology.
Yeah,
And
we don't know if she really would have behaved the same way at the end of 6 months, even if we didn't give her immunotherapy.
But I guess what I would say is that it doesn't matter if you transplant the patient up front or you give the local regional therapy. All the local regional therapy is doing is saying which 22% or 30% are going to have bad tumor biology and they would recur post-transplant. So there's no harm in doing the local regional therapy to select a good tumor biology. You can work the patient up for transplant during that time. You can get the living donor ready. And then do your local regional therapy. You can do anything. It doesn't really matter because if you're going to transplant the patient, it doesn't really matter if the patient has liver dysfunction. You're going to take the liver out. Be aggressive with your local regional therapy, induce the response, and then transplant them. But it doesn't, the systemic therapy is more so if the patient wasn't going the transplant route, that is the better.
When you start the systemic therapy, you have to have a clear endpoint.
You are saying
I think at the end of the day, you always should know
endpoint?
where you're going. Driving to drive without a destination is a bad idea.
Yes.
So
So
you
I think when
always-
we start a treatment, I think we all should have a certain endpoint.
But it requires a discussion with that
and I
patient. Let's say
think
this.
Pala has
if you
something
talk to this
So
patient-
basically, you're saying that it should be selection with time. You give
Tumor biology
immunotherapy,
is the
if
key
they
to the land.
respond, fine. If they don't
Tumor
give,
biology drives everything. That's the goal that I think, and that what we are
but
doing.
in a setting of living donor transplant, if they are transplantable, they should be transplanted upfront. DDLT maybe.
I disagree, but that's a matter of
This is the
opinion.
usual.
You're putting that donor and you're putting the patient through a transplant, and if they recur, the thing is, post-transplant, you don't have the IO agents. You can't. You have ciforadenib and lenvatinib, but you actually take away. You tie your arm behind the back for someone who has
Since,
recurrence post-transplant.
You're here, like to hear your post-transplant and the role
It's
of
a bad
immunotherapy.
disease.
The role of immunotherapy.
We don't use immunotherapy post-transplant. That's why you tied one hand behind your back. And what we end up doing outside of oligometastatic disease, which you can treat locally, single oligometastatic disease to the adrenal or chest wall, et cetera, we treat that locally. But otherwise, what you end up doing is cycling through all your TKIs, and then you just shrug your shoulders because you don't have anything left. It's a bad disease.
The middle path would be original then transplant. The middle path between these two would be a local original
Yeah,
therapy.
I think we have to figure this out. And I think that, this whole idea of liquid biopsy or biomarkers, we have to figure out better selection than just saying the Toronto idea in terms of biopsying this is reasonable, but I think there's probably a non-invasive way to measure this. I mean, I think that we're going to get smarter about it.
After a heated discussion, I'd like to conclude this evening. Thanks to surgeons who made it more interesting debates. Dr. Jiviraj sir, Dr. Bala, Dr. Suman. You have Dr. Jiviraj sir. What do you want? You have sir here. But anyway. Dr. Sir, Dr. P. Sir, can you please felicitate? I would like to thank Dr. Amit Singhal for coming here and for enlightening us. I have learnt a lot. I hope everybody has learnt a lot. Please, can you come here and felicitate Dr. Amit Singhal on behalf of AIG. Sir, Jiro sir. Gupta sir. Gupta sir. Thank you, Naveen, for coming here and discussing the cases. Dr. Ravi Teja, thank you very much. Thanks to I would also like to thank Dr. Rajesh Kote from Vijayawada, Dr. Deepak Vaisi from Rajahmundry, Dr. Shilpa K from Vizag for joining us through Zoom. And it's been a great honor to spend the evening here. Join us for dinner. Yes, sir. I would like to thank Roche, Isai, and Cipla for their educational grant for this evening. Thank you all. We'll have a photo together.